Stakeholders Workshop. Thank you for taking the time, especially for many of us that came in yesterday. They're going to be here through the week. We appreciate the time that you have taken on this, knowing that this is not your primary assignment, but you give it much attention, so we are grateful. Thank you. And I'm sure the patients will thank all of you at the end of the day, because ultimately, this is for the betterment or better outcomes for our patients. My name is Tayo Ajayi Oba. I tell people I'm very far from a doctor, so I'm a mister. For the sake of all of those online too, you're welcome. We're going to run a little bit behind schedule because the MPIs, they are stuck in some engagements or the other along the road. So they'll be here with us very shortly. As you all know, it's a collaboration with New York University. So we have two of one of the MPIs and also another facilitator from NYU. So we had some training yesterday, but they're on their way very shortly. I'm going to hand over to Professor Maxwell, who is in charge of our skills development work group in Accelerate. And maybe just to take a little bit of a time, please remember that each of us is going to present, that's all the site leads, a 5-minute clip on your facility. So if you have that ready and we need to put it on the machine, please let us know. Secondly, I think it's a good time to make some introductions while we kind of kick off officially. The people online, we can't introduce you, unfortunately, at this time. So for those of us in here, we'll make introduction. Professor Maxwell. Okay, and then one quick housekeeping matter. The attendance sheet Google document is already online. For those online, please register. Just click on it and register. Thank you. Good morning, everyone. You're all welcome. I'm hoping the stay here is fair. Oh, apologies about that. We'll need to talk to them. So once again, you're all welcome. We are probably yeah. So we're going to start with introductions, but just to mention that if you have your presentations, we want to put them on the system that we're going to use. If you have it in a flash, we'll collect it and load it up. If you don't have it in a flash, we can provide a flash just to copy it. So we can load it on the system that we'll be using. So while we, once again, apologies that we're starting behind schedule. While we're doing this, hopefully the team from NYU will be here for us to fully start. So I want us to quickly have some brief introductions. Mr. Tayo has introduced himself. He's actually the program manager of Accelerate. The rest of the team here are all members of CESTA. My name is Maxwell. I work with the University of Abuja. I'm also one of the research team members in CESTA. And I think it's only up that we start from, yes. Yes, sir. You're welcome, sir. You're welcome.
welcome. You're welcome, sir. Those of us who are, please, man, let's move to the site. You're welcome, man. Well, welcome, sir. You're welcome, man. You're welcome. You're welcome, sir. You're welcome. Welcome. You're welcome. You're all welcome. Now let's have our own introduction. Those of us who are here. You're welcome. Okay, so now we have our data team people. Please quickly introduce yourself. I'm sure people make it. Okay. So once again, you are all welcome. I think the next thing that we have based on our schedule is the presentations from the various sites, just talking briefly about their sites, the clinical workflow. Then, like I pointed out, if you have your presentation in your slide in your flash, if you would like to copy it so that we can use our system to do the presentation. So they just take a few minutes, the next few minutes to load up the slides or have yes, slide. It's only kept that sent. Please, if you need a flash, or you. Okay, maybe you Mr. Ruben. Yes. I want to believe you all have Ruben's. It's part of the WhatsApp, so you can just. Yes, yes. Okay, so yes, so please you can there's check for when 5G and just check and another one with Airtel. CDN of those one is empty and the other one is. MTN, something MTN 5G with 5G. And you see, so you can log in so that the password is JER, after letter J. Yes, letter J, capital ER. ER is not capital. Just J don't is capital. JER 30. No, 30. Just 30. 30. V, small letter V, 19. So JER, after letter J, ER, 30, B, small letter 19.
And you also don't have trying to collage. She brings the things over from she must have been, somebody was there. I'm trying to be on the prominent list. As we were setting up, I think our team from NYU came in. So maybe they can have introductions also from both of you. Well, maybe you can come here for the sake of the
online folks.
Yes. Okay.
Good morning, everybody. Apologies for being late. Just had a little bit of difficulty. My name is Emmanuel Pepra, Dr. Emmanuel Pepra from NYU. I am the MPI for this grant with Dr. Nudu, and I'm very happy to be here. This is one of the most exciting work that we're doing in terms of sickle cell disease, trying to figure out how we can improve hydroxyurea uptake among patients. Of course, all of you are providers who are eminent in your field in terms of managing sickle cell disease in your various areas. So what we're trying to do is trying to help you in the best way that we could in terms of trying to figure out how we can really assist in terms of providing provider-driven training to increase hydroxyurEa adoption. So over the next couple of days, we're going to go through the protocol. I'm going to give you a high-level overview. And then, of course, we're going to also talk about the training in terms of it. So we're here in terms of answering any questions that you might have about what we're doing. And we're excited about doing this for the next 2 years or so, and then figuring out what the results say in terms of how we can increase adoption. So we're hopeful that what we propose in terms of an intervention will be helpful in terms of the context. So it's really a pleasure to be here. And as an introduction, I am going to introduce my new colleague who just finished with his doctoral degree, Dr. John Patenya, who will also be assisting in terms of providing some of the training. So John.
Good morning, everyone. Thank you for having us here. My name is John Patenya. I'm an adjunct instructor at NYU. My focus is providing mental health for sickle cell disease populations, and I'm here as qualitative analysis as well as the. So thank you for having us, and we're excited to be here. Thank you.
Welcome once again. So we're just going to start with the presentations from the sites. As more come, we load them up. So we'll start off with the ones that we already have. So Mr.
Change it. Okay, good morning, everybody. My name is Dr. Timothy Ekwere from University of Uyo Teaching Hospital. I'm the site lead for the SPARC-NET site there. So I will just briefly talk about the clinical workflow at my center. We actually joined the SPARC-NET network in 2002, and we've been part of the team since then. Formally engaged in 2 major projects of the SPARC-NET, that's the newborn screening using dry blood spots, and then the mother and child screening using hemotype C. So these are about the 3rd projects we'll be engaging with SPARC-NEt. So I will just So our clinic day, I'm an adult hematologist, so we don't have a separate sickle cell clinic actually, but we run it alongside other hematological disorders. So our clinic day usually on Tuesday today, and it starts 2 p.m. However, the process for the clinic starts in the morning. For the pediatric hematology clinic, because I work hand in hand with the pediatrician, and we tend to recruit patients from both sides. She's online in this program currently. She couldn't attend. The pediatric clinic holds on Thursday from 9 a.m. For the adult hematology clinic, the first thing is the check-in and the registration. Like I said, the clinic starts 2 p.m., but the activities for the clinic start in the morning. The patient for follow the record officer at the hematology daycare. We have a section in the hospital that is dedicated for hematology. That's where we have our daycare as well as our consulting room. And also we have a separate record for hematology for whatever reason. Hematology is the only department that have a separate record housed within the hematology daycare. So when they come, they submit their cards for retrieval, and the record officer retrieve the cards for them, and then they proceed to the waiting area. For new patients, generally we receive referrals from GOPD. If they come in steady state without crisis, we don't know them, then they go through the GOPD first. We will see them and refer to hematology. And then those that come with crisis go through the accident emergency because we don't know them. So they don't come directly to the hematology daycare where we have a sickle cell patient managed for crisis. So, and the daycare opens 8 a.m. to 6 p.m. Monday through Fridays. After retrieving the card, the initial assessment is done by the nurses at the daycare, usually taking up the vital signs, and of course they will give some health talk. Then for the new patients, the assessment is done by the registrars. They have to take full history and then do a thorough clinical examination. And then they also go through laboratory assessments still at the daycare there. For us, all patients are required to do at least a full blood count and minimum a packed cell volume for review. All the patients are aware. For those who can afford, at least a PCV is done. The PCV is usually done free for those who can afford by the residents. We have a hematocrit centrifuge by the side, so they spin and report the results so that can be used to assess them for the clinic proper. Sorry, next. So the clinic proper starts at 2 p.m. in the afternoon. So after the assessment, the patients are free to go, or they can move to the waiting room where they can wait and be entertained. There is a TV there where they can wait until 2 p.m. or they can go and come back. So during clinical consultation, we interact with the patients. Treatment is offered if needed, or further investigation, or even referral to other specialists is done during that interaction process, which may last 25 to 30 minutes, depending on the complaints which the patient came in with. And then, of course, we carry out the follow-up appointment is given at that point. And after that, the nurses takes up the appointment given, pass it to the record officer who puts it in the appointment register. But we also, especially for the sickle cell patient, we often tell them that despite giving you this appointment, anytime you have a problem, you can always come back. And many of them do that, especially when they have crisis before their next clinic visit. So that's a very important message we always give them. Anytime you have any issues, you just present back. Next. So our site staff, we are 3 hematologists in my department, and we have 8 registrars, 5 of which are senior registrars, and 3 junior registrars. We have 4 nursing staff. One of these nursing staff is permanent at the daycare. She herself is a warrior, is a sickle cell, so she's permanently there all through. The other 3, based on the posting by the nursing service, but they come and stay a minimum of 4 to 5, 6 months. So, but the head of the unit, which is the matron there, is herself a warrior. She's permanently there all through. She part of this project. Then we have a laboratory scientist. When the samples are taken by the doctors, the laboratory science, actually a technologist, will take it to the lab. The samples are run and ensure that the results are brought back before the clinic starts by 2. So he's also a permanent staff of the hematology daycare area. Then we have a research assistant, which we employed for this project. And then, of course, we have a pharmacist, not stationed at the daycare center, but in the course of this project, she's willing to work with us. So she'll be part of the project when we start. And then, of course, we have our research assistant. Then, of course, we have other medical specialists that we normally refer to in each of the subspecialty. We have a specific nephrologist that has interest in sickle cell disease. So that's as part of our multidisciplinary approach, as well as an orthopedic and the plastic surgeons that comes in handy when we need them. And then usually for those, we send them to ophthalmology review once every 6 months. Okay, majority of them do attend, but some may not actually do. For the laboratory investigation, like I said, baseline full blood count every clinic visit, minimum PCV for review of all patients. But there are other basic investigations that could be done in the hospitals. All basic investigation, generally we will do it. Full blood count, electrolyte, liver function analysis, LDH assay, those ones are done. But LDH, now I heard, is done on request because from the chemical pathologist, the request doesn't come full frequent. So if you want it, you tell them ahead so they can arrange and do it. Then hemoglobin F %, we usually don't do it. When we need it, we send it to external labs, as well as iron and serum ferritin. These ones are not doing regularly. Other highlights, what we do, sickle cell support meeting, we do this every 3rd Sundays, every month in conjunction with it's an NGO, Sickle Cell Warrior Health and Healthy Living Foundation. They actually sponsor the support group. We meet every 3rd Sunday in the month. It's more like a discussion trying to teach them preventive strategies to prevent crisis as well as healthy living. Then, of course, we do some advocacy as well. NMA has this health talk sponsorship they do, so they call in specialty by specialty. I think ours will be in May, hematology will be in May, so we'll use the opportunity also to do some radio advocacy. NDCAN also has their own, as medical and dental consultant, sponsored program on the radio. So we key in on all of this to further create awareness for sickle cell. So in a nutshell, those are the things we routinely do in our center. Thank you.
Basically note things and discuss at the end so that we can just go through the presentations. If anybody needs writing material, please just indicate so we'll give you 2 minutes. So the next presenter.
All right. Good morning, all. Mbanefo Francis, and the present head of the departments of as well the SCD program coordinator of Federal Medical Center Kefi. So Federal Medical Center Kefi is in Nasarawa State. That's a close door neighbor to Abuja. So we can say it's a stone throw from this place. And it's one of the Federal Ministry of Health designated special care center for sickle cell disease. And it has been operating as such since 2011. Oh, no. Well, this is the clinic workflow of the hospital. You know, normally a patient comes to the hospital, the first place to go is the medical records. The hospital operates an electronic medical record system. So in the electronic medical record system, the patient ID is activated. Activation means you have paid for that particular day's consultation. The activation gives access to the doctor, the pharmacist, the lab scientist for subsequent tests if need be. It also gives them access to the nurses who are going to do triage, because after the triage and the vital signs, the data is now open to doctor for review. So from the medical records, the patient moves to the clinic area. In our clinic area, we have an information desk. That's the first point of call for the patient. In that information desk, the data of the patient is taken, how do I put it now, manually by the record staff, the scientific officers there. So we have our own register note that they document hospital visitation, take the vital signs. If there is need for any forms to be filled, they take the biodata of the patient and give the patient the form to proceed to the next area. After the clinic area, the patient goes to triage room where the nurses are. The vital signs are taken, height and weight measurements done, and imputed into the data for the doctor to see. So after the triage room, they tend to stay in the waiting list for their turn for consultation. Then after the doctor's consultation, they move back to the information desk. For the patient, the desk officers, the scientific officers, they take notes of what was done for the patient, then complete the form if the doctor has filled it, and check for those not filled to remind the doctors to complete the form. And from this information desk, they are directed either to go to the lab, you can move on, or the pharmacy. Now, if they go to the pharmacy, sometimes because of technical hitch, the information input by the doctor may not be sent to the pharmacy or the lab. They have to go back to the information desk to complain. So the desk officer there will allow the doctor to cross-check what is on the system to be sure it has been posted to either the lab or the pharmacy for the patient to assess. That's the way it is. So the patient can decide which one to go first. If there's a request for medical lab or pharmacy, you can choose to go to the medical lab and from the medical lab to the pharmacy and vice versa. If you're having an issue along the line, you report back to the information desk. Move on. That's basically the workflow of the clinic. The clinic is, you missed one, the clinic is mainly on Thursdays, both the adults and the pediatric clinic. And these are the staff distribution. It's good to note, in Federal Medical Center, we have the SCD program as a program where they have their own staff attached to the program. And we have other clinics, Obs and Gynae, internal medicine clinic that still run one or two SCD programs, but there's a program with composite staff. This is the composite staff of the hospital. We have 4 hematologists, we have pediatricians, and we have other consultants in the multidisciplinary approach who are part of the SCD program of the hospital. As I earlier mentioned, is one of the special SCD programs by the Federal Ministry of Health and Social Welfare. So these are the distribution of the staff in the SCD program, but there are other supportive staff in the main medical lab and the pharmacy. We have other staff supporting the program. Move on. So access to the relevant lab test. As already shown, the basic lab investigations are present in the hospital, apart from fetal hemoglobin estimation. and maybe retic counts. Because of the cost effective of the tests, most of the time is the reagents are not stored by the hospital. So we tend to liaise with external lab. It's also good to know that the hospital runs a public-private partnership in the area of medical lab services. So most of the time, the private components of the services will liaise with them to get some of the lab investigations that are not available in the hospital. Next. Okay. So not okay. This is just about the next thing is how many patients do we see? Basically, per month in the pediatric clinic, we see between 60 to 80 patients per month. Then in the adult clinic, we see around 30 per month. It's good to note that out of all these patients coming to the clinic, about 35% of them are under the National Health Insurance Scheme. I know National Health Insurance Scheme, they have their own limitations in the services they can access. That's basically how the hospital flows. And as part of the research, we've been part of many ongoing research with SPARC-NEt. You can go to the pictures, leave it, go to the pictures. Okay. Just change the background to light. So. Okay. Okay, the next slide. So I've already enumerated on this. About 30% of the patients presenting to the clinic are under the National Health Insurance Scheme, and they can access the available services within the National Health Insurance Scheme. That's basically the next slide. How the clinic is the information desk where the patient first comes to the clinic. We have the scientific officers and the nurses who are there to take notes and record of what is happening. The next one. Then from there, they send to the attendant who now directs them to the triage room. Next, this is the triage room. Normally, it's the vital signs. They take the vital signs of the patient and input it into the system for the doctors to have access to. The next one. This is the waiting area. So many things happen in this waiting area. This is where the health education is given to the patients. The nurses, they can do their health talks and all those things. And those who have one or two things to do, even to sell, those are the places all those things are done. So the next one, these are the clinic consulting rooms. This is the first consulting. Yours sincerely is there consulting. The next one, this is still the consulting room. Continue. This is still the consulting room of the hospital. Continue. Still the consulting room. So after consultation, you go back to the information desk for the data to be taken. And from there, you're referred either to the lab or to the medical or to the pharmacy for further services. And if you have issue, you come back to this desk for further clarification. I think that's all of our clinic flow. Thank you very much.
Morning all. Okay, my name is Dr. Collins Maduka. I'm the site lead for Waggalada Town Clinic. All protocols duly observed. With your permission, I would like to express my excitement on going through the protocol as an implementation student. I found out that the EBIs framework utilized in the protocol covers the implementation ecosystem. With that, I want to delve into my own clinical flow. Waggalada Town Clinic is a primary health facility, a 10-bedded primary health facility. Yes, it may be small, but what we lacked in size, we gained in clinical capability. As we boast of over 200 sickle cell patients in our registry. Our clinic day is basically on Friday, and our staff strength includes 1 hematologist, 3 hematology nurses dedicated to accelerate program, 3 laboratory scientists, with 1 who has a WHO certification, 2 laboratory technicians, 1 pharmacist, and 2 pharmacy technicians. This is our clinical workflow. Basically, we have a reception where these patients are exposed to virtual and interactive sections, talks on nutrition. We also have a clinical psychologist that evaluates them day and weekly on the psychological outcome. From there, we move over to the medical records, which is a non-virtual record, so you still use a paper-based record system. Eventually to the nursing station where vital signs are taken. And finally to the physician's station where the doctor sees these patients, evaluates them, decides whether they will need a further psychological evaluation, or eventually they move over to the laboratory section for the investigations. And finally to the pharmacy, and eventually they leave the hospital. We do not admit overnight admission for these patients. If need be, we may refer them, being close to UATH, we may refer them to UATH for further treatment. So for our investigations, for the in-house investigation we offer basically basic investigation like urinalysis, pregnancy tests, renal function, and liver function. Now, since the accelerated program requires further investigation like the retic counts, hemoglobin F quantification, we have an agreement with UATH where we can do these investigations as part of our accelerated program. I think that's that. Thank you very much.
So good morning, everybody. I stand on existing protocol, and I want to say I'm really excited for the opportunity for Maiduguri to be part of Accelerate. Is indeed a big opportunity for us to be able to improve sickle cell disease management by trying to provide hydroxyurEa within the Accelerate study. So we hope that at the end of Accelerate, we would have learned so much that it will translate into improved sickle cell disease management after the project would have finished. And I'm really excited here to be able to meet Dr. Emmanuel Pepra in person, and my other colleagues. And so thank you once again. So I'm just briefly going to describe the clinical workflow for University of Maiduguri Teaching Hospital. And so basically, next slide. So in terms of clinic, we have a clinic day for adult hematologists and for pediatrics. For the adults, our clinic runs on Tuesday, and on average, we see about 20 patients per clinic day. And then for the pediatrics, they have their own clinic on Wednesday, and they see about 30 to 35 patients per week. And apart from the clinic, there's when we have patients that require acute treatment, we see them in the daycare. So for the adults, we see patients daily, and we see about 21 to 30 patients per week. For the pediatrics, if they have any acute crisis, they go to the emergency pediatric unit where they see them daily. And then I think on an average, we have about 20 to 25 for the pediatric patients. Next slide. In terms of our site staff composition, so we have, we're one of those centers that are fortunate to work very closely with the pediatricians. So we have about 7 of adult hematologists, ranging from professors, associate professor to senior lecturers and to lecturer 1. We have 3 pediatricians. We have an adult professor as one of our team member. And then we have 2 senior lecturers. We have 2 medical laboratory scientists. We are still trying to co-opt pharmacists into our Accelerate program. And we're already in talk with the pharmacy department for that. We have 2 research nurses, and then we have 1 research assistant. And then we also have a nurse counselor that is currently undergoing a training, so that we'll be able to use her for subsequent program. Next slide. And then in terms of the kind of laboratory tests we offered in-house, we're able to do complete blood counts, and we're able to do baseline biochemistry, renal, liver function tests. We're able to do immunological markers for HIV, hepatitis. And then so our daycare is situated close within the blood bank premises. So that sort of facilitate transfusion service for our sickle cell disease patient. We also have close link with the radiology department, and then some of the investigation we can do include plain X-ray, ultrasound, or depending on what organ we want to. So these are the basic investigation that we're able to do. In terms of those investigation we cannot do, we already have collaboration with a very reliable laboratory outside the hospital, where we've started doing investigation at Ferritin, and we hope to build on the type of investigation we'll be doing with those laboratory that are external to the hospital. And then next slide. In terms of highlights, what we want to project as highlight here is in Maiduguri, we have a sickle cell disease research group. We consisting of 20 members and cutting across different specialties. So we have pediatrician, like I've said, we have the adult hematologists, both from University of Maiduguri Teaching Hospital and the close by state hospital. And we have community physician amongst us, and then we have a research assistant. And so all in all, I think we're about 20. And the name of this research group is STCare. We stand for Sickle Cell Team for Care, Advocacy, Research, and Education. And we've sort of coined this acronym, and we have working groups. So each of us in the sickle cell disease are assigned to a particular acronym. So we have people that are responsible for care, and then we have those for advocacy. And the whole idea is to have, like, in a year, what is the plan that we want to do for our sickle cell disease patient, and want to be all encompassing, focusing on different aspects of care for sickle cell disease. So to summarize, in Maiduguri, in terms of patient care highlights, so for patient attendance, I've said that we have about 20 patients, and in the adults, and about 32 to 35 for the pediatrics, and then we have a daycare service, and then on top of all this, we also have a research initiative. So that's that from Maiduguri. Thank you for listening.
Thank you very much.
I don't like to stand for ceremony, but I'm really, really happy to see all of you. It's wonderful. really we went to find out why this was so. And so other studies were done. And from that was what informed Accelerate. So when we came to Accelerate, we needed to, is clinical trial. We had done registry study, and the data from that was suggesting that perhaps the follow-up was not as vigorous as it should be. But we know that we are being opportunistic, right, about the work we do in SPARC, because we just do the follow-up as the people come in. We don't have enough money, on the ground to do active follow-up. So occasionally we would, I think when we had a little supplement, we did some active follow-up, but that was only 75 persons per site. So we now say that if you're going to do a clinical trial, it has to be on patients who are committed to coming to care, right? And it has to be on sites that are committed to follow up. So basically, and the enrollment in the first instance, so we took 300, sites that had enrolled over 300 patients and above over 6 years, right? So that was what we did. And then not only that, not only have they enrolled over above 300 patients, but we wanted to have sites that were showing a little bit of seriousness in terms of follow-up. So these are the people that we called, to participate in this study. So that is how. So if you're wondering how we decided, and whatever else we are doing, whether it's a malaria study which Professor Madri is heading, we are looking at the data. Everything we do, we look at the data from the registry, and then it's on the basis of that data, that we take. So you can see Timothy Ekwere, who joined in the last iteration, in the very last year. In fact, I think you joined in the new SPARC-NET. You joined SPARC-NET, so he's here. And then Dr. Ofakunri, who joined almost the last month of the SPARC 1, and he is here. So we just look at the registry, and then we use the registry to make a decision. And I want to say that going forward, even our friends, our colleagues who seem to have fallen behind, we are still going to, that registry is here to stay. We are still trying to see how we can support us to focus on the registry and to continue to do follow-up on the registry, because that registry is a national resource. And that's what we have. So we are not going to leave anybody behind. But when we want to do clinical trial, we want to make sure that people can follow. So this meeting is very important. I thought that we should come here. So that we would look at the volumes of documents, the protocol that we have. We should look at the CRF, and then we should see the workflow at our site, and together, shape how this research is going to take place. Because once it's a clinical trial, then the data has to be, perfect, almost. It has to be perfect. The NIH will be looking, all the data as we are keying them in will be coming up on the dashboard, and we will see that. So this is supposed to be a workshop, an opportunity for us to come together, and then we are observing, what is going on at the site. And the question would be, how are we going to implement this at our site? So I'm really excited, to see all of you. And I know that we are, IJ. Yes, so you're really welcome. You're welcome. So we are going to also have to, kind of piggyback a little bit, take the opportunity that you're here to piggyback on some new ideas that are coming from our young colleagues. So thank you very much. Yes.
The next. Good morning, everybody. I want to thank the organizers of this program, Professor Nado and Pepra, for all the effort they have been putting into this program, pushing and dragging all of us. It's not easy for them to bring all of us here. So I want to appreciate them in a special way, and thank God for bringing everybody together today for us to brainstorm on the way to carry out this project perfectly. I'm the site lead for LMlCs Federal University Teaching Hospital, Abakaliki in Ebonyi State. We have over 1,000 patients registered in our center, and there are clinic days and Wednesdays for adult patients and Thursdays for pediatric patients. The workflow is when patients come, they first of all present to the record unit where the case notes of the patient will be called up, and then the patient then moves to the nurses' bay where vital signs will be taken, and then the patient will now sit at the waiting room. While sitting in the waiting room, health talk will be given to the patient by the nurses. And then from there, the patient will now move to the consulting room. Next slide. To the consulting room where the patient will see the doctor. And of course, in the consulting room, we normally take history or of the presenting complaints of whatever the patient come with, do a normal physical examination, and then make laboratory requests. The patient to medications or to the lab, sometimes to do some investigation, depending on whether investigations are requested at the point of consultation. Then the patient from the pharmacy there, of course, the patient will also go to the revenue unit to pay for the drugs. If it's investigation, he or she will also pay for the investigations that are requested. The investigations, either laboratory investigations or radiological investigations, sometimes they will pay for those investigations, and then the investigations will be carried out. And of course, the patient will also be given appointment dates for the next appointment, which will be recorded in his or her card, for subsequent visit. Next slide. Our site staff, we assist 24 nurses, pediatricians. We also have other multidisciplinary team. We have the cardiologists working with us, orthopedic surgeons, gynecologists, radiologists, anesthetists, plastic surgeons, psychologists, ophthalmologists, nephrologists, and so on. These are people from other specialties, in our multidisciplinary team that also helps us to manage the patient depending on whichever complications. For instance, the plastic surgeon, for those of them that develop leg ulcer, in the course of management, they help us to follow them up and treat them depending. And then, of course, those with that will come in with some gynecological problem, or even some with pregnancy, the obstetricians will also help us. And we have dedicated people in each of those specialties Not that this person will see next time, the other person will see another time. We have one person that is in charge, so that over time, that person will give us his or her experience, over time, having been seeing the patient. A majority of lab tests are done in-house, like a normal routine football count, blood film, renal function tests, liver function tests, and so on. For those that we don't have within the hospital, we have good laboratory outside that will do them, like sometimes we want to assay for some ferritin, for instance. We want to check for those that have iron overload, for instance. We do few outside, but most of our investigations are done inside the hospital. Next slide. We have, because when I said we have 24 nurses, some people were like, wow, how did you have 24 nurses? We have dedicated sickle cell center where we run 24-hour service. So those nurses, they run shifts, morning, afternoon, night, and we admit patients there. Our patients are admitted there. We run 24-hour service. Everything about sickle cell, that's our dedicated center. We will have dedicated pharmacy. We have dedicated records, revenue, everything. It's just like one-stop shop. Patients comes, every service is provided there at that center. So that's why we have that number of nurses, because they run 24 hours, just like the way we do in our wards and all that. And patients are admitted there. Even the cases that present in crisis, they don't go to A&E unless the patient is coming for the first time. Does not know that we have dedicated, but those that have been registered are coming. Once they come and say, we have sickle cell patients in A&E, we're like, they didn't know where to go, So that's why we have that number, and we run 24-hour service. Everything is provided. They dedicate, the pharmacy is there, the record is there. Their case notes are not at GOPD or general places where you have record for for sickle cell patients only, both adult and pediatrics. Everything is there. So that is another thing I want to draw attention, so that we know why we have those number of staff. Thank you very much.
Good morning, everyone. Professor Nodu and Professor Pepra, been quite long. I saw you last. Welcome. So I'll be representing UCH. My name is Yobele Brown, and I'm the site lead for the hospital. Next slide, please. So we have UCH, as we know, is the teaching hospital of the University of Ibadan. It's a referral center for Ibadan and other parts of Nigeria, and even within the West African sub-region, especially in cases with cancer. It has a 900-bed capacity hospital, and we have inpatients and outpatients. For our pediatric inpatients, we have like 30 to 40 patients per clinic day, which is on Thursdays. So overall, we have over 500 patients. Indeed, if you have more than this, but a few of them come just for the TCD clinic. They think TCD is everything and don't come for the routine clinic. I can't see here anymore. Next. So before that, so patients come into tell the workflow from family medicine at GOP, or from outside UCH, or from within clinics within UCH. Example, the child has some eye issue, maybe cataract, wants to go for surgery, and they do the routine screening and find the SS, and then they get referred to our clinic. We also have so when they come to the clinic, the nurses see them and send them to the health records, who register them for a fee, except those with the NHLBI. So entry of our patients, or the pediatric patients, comes in through the outpatient clinic or through the children's emergency ward. The adults have a daycare center for hematology, disease, and malignancies. So patients can also come in through the HDCU to UCH for care. The clinic days are Tuesday afternoon for pediatrics and Thursday afternoon for the adults, the medical outpatients. Patients can be seen either in the outpatients or the emergency ward, and then referred to the ward for admission if indicated. They are asked to arrive between 11 and 11:30 a.m. They pay for registration, the vital signs are done, the nurses do the triaging, and then they all go for PCV and blood pneumonia parasite, which is routine in every clinic. And then the public health nurse gives them a health talk, and then those for routine TCD are then separated and wait for the TCD to be done. All new patients are practicing, but all new patients are seen by the consultant. And then the follow-up patients are seen by the resident doctor. So they send to the consultant only when there are some difficulties or challenges in taking the correct decision. Appointments are 3 monthly, and new patients are also given appointments. So you don't just can't just barge into the clinic. So new patients come in by appointments given by the nurses. The challenge we have, I'll talk about it later on, and patients are referred to adult care at the age of 18 years. We have tried to do that earlier, but some consultants will not accept them in the adult care until they are 18 years. But the few will accept. The reason is that some entered in the university at the age of 16 or 17 year university students, and then you need to be admitted. How do you stay on the same ward with 3 or 4-year-old children? But that's a challenge now. So off record, I've been able to find a few consultants who are willing to take our children before they get to the age of 18 to the adult care. We are considering some transition clinic, but they are so short-staffed that it's been difficult to start a transition program. Lab scientists are available. We have a pediatric laboratory in the clinic and outside the clinic. So we have many library scientists with us, and also we have access to them in the rest of the hospital. We also have in our research team for other sickle cell work, we have 2 dedicated medical lab technologies. And all major categories of lab services are available. Histopathology, hematology, microbiology are all available. We also have 2 research things elsewhere. We are difficult getting somebody here because they're always traveling. So most tests can be done in UCH, but those cannot be done in UCH are sent to private laboratories which are nearby and get the results. We also have 2 genetic counselors who have been trained also within our clinic. One is a nurse and one is a social worker. Challenges, that slide. The adults, this a massive exodus from Nigeria to healthcare workers has affected us very, very badly. In the last set of SPARC follow-up data, the hematologist said he wasn't doing anymore. Well, he didn't have resident doctors to join. So even in the current follow-up, and even in Accelerate, at present now we have just one resident in hematology in UCH, just one resident. And he counts on them, not just a research assistant, to assist with the work. So for the Accelerate, they have not been involved. And I think they regardless of me to try to push it, because that same one resident that they have was recently assaulted by some patients. And he was busy in the emergency ward. A patient had died, and they are waiting for them to give their certificate. So before he arrived, they thought he was missing their time, and they assaulted. So for the Accelerate, that's the reason why we have not been able to get the adults into the shortage. For pediatrics as well, we have challenges are so short. I'm the only one in there, but I'm hoping that somebody will join us very soon. All right, that will make us 2 in pediatrics. So I think that's it for now. Thank you very much for your attention.
Good morning, all. My name is Hassan from ABU Teaching Hospital in Zaria. And it's a great opportunity to be here once again. Like my elder brother, Coach, has said, it long that we met. We've been zooming for long. So thank we're here today, and it's an opportunity to meet. It's nice to see. So I'll just be presenting the site. Next, please. It's a federal tertiary hospital in Nigeria. It has an 800 beds capacity. It's located in Zaria, Kaduna State, Northwest Nigeria. It has the full complement of all clinical services, and is also a center of excellence for oncology and now for kidney transplantation. Next slide, please. Currently, our site, we have 12 consultant hematologists. However, about 4 of them are more into oncology. They are into oncology, 4 of them, but the remaining 8 mostly do sickle cell disease. We have 10 resident doctors. Most of them are senior registrars who are about to graduate, so we may not, I hope we don't fall into the same trap like UCH. We have 4 dedicated nurses that work with us in the sickle cell clinic. However, the major challenge is the turnover. After a while, they will say director of nurses has moved them to surgery, have moved. So after we finish training them, they move. But we'll be lucky to have one lady that has been there for some time now. She's probably going to retire there. We have about 12 laboratory scientists in the department, and 3 have been dedicated to sickle cell. We have about 15 laboratory technicians. We have 3 dedicated. And how did we get them dedicated? Usually when we have fundings or trainings or seminars, we get 1 or 2 of them to join us or attend and what have you. That way they develop interest, so that anytime we have any issue related to sickle cell, they actually come around. We have 1 statistician and another one also who is trying to assist the other one. We're trying to bring him in, though he's also busy doing oncology and other things. We have also a robust sickle cell support group known as Sickle Cell Warriors and Awareness Support Group that we work with. They are the ones that help us mobilize patients anytime we have programs like this. Our clinic runs every Tuesday at the Polyclinic, and we have a daycare service that has a 3-bed facility that runs from 8 a.m. to 4 p.m. Monday to Friday. However, outside these hours, patients who come as emergencies are seen at the medical emergency
by family physicians who we have a very good rapport with them. They actually inform us that we will have patients, and then our residents on call will go and see the patients before they get transferred to the clinic. We have about 1,500 patients in Zaria. About 1,000 we say are active. Anybody who has been seen at least once in the last 1 year, we say is an active patient. We have about 605 on the SPARC-NET database. And so far, we've enrolled the required number of patients for the Accelerate program. Next slide. This is our daycare with some of our nurses, like Matron David. Yeah, the David, the one that is smiling there. Yes, she's been with us for almost 7 years now, and she's not been moved. We're hoping that she will still stay there. We've done a lot of training for her, and she's very comfortable with sickle cell patients, and they're always happy with her. Yes, next slide. So available investigations, we do all the basic investigation, full blood count, differentials, blood film, HB electrophoresis. We have the variant HB electrophoresis machine, but unfortunately, it's faulty. We do other support investigations in chemical pathology, radiology, and co, as the case may be. We also have the capacity for drug monitoring at the multi-user research lab at the Faculty of Science. In my center, they're trying to not have every lab has something, they centralize things. So there's a lab called the multi-user research lab in the Faculty of Science who can do drug monitoring for us. Our workflow, similar to all the other centers, new patients still start going to the records. From there, they go to the general outpatient clinic where they are seen by family physicians. Then they are referred to the hematology clinic or daycare, as the case may be. We have a good interdisciplinary team work with many people, for instance, the pediatricians. They have a lot of patients, and we've started running what we call the adolescent clinic. It's a transition clinic we run with the pediatricians on Thursdays. These are patients who are between 15 to 16 years, so that it will be easy for them to move. Like Professor Biobele said, sometimes we have this issue. A woman has 3 children. One is 18, the other 2 are less than 18, and they still go to pediatric clinic because it's 1 day transport. Otherwise they have to go to clinic on 2 different days. So we have to get them through the adolescent clinic where we talk to them about healthcare, reproductive health, and what have you. And they get used to the adult physicians and they start coming on their own. We also have good working relations with orthopedics, obstetricians, urologists, and what have you. Our patient flow, usually in the clinic days on Tuesday, we see about 60 to 80 patients. However, that has dropped drastically. Now we see maybe 20 to 30 because the cost of transportation within Zaria, our hospital is outside the town. It used to just cost about 400 to 500 naira to go. Now it's about 1,500. And patients now wait until when they are sick. It's really unfortunate. Yes. Next slide, please. Okay, the daycare, yeah, the daycare too, we see about 5 to 10 patients. That is both sickle cell, oncology, and but 3 to 5 are usually sickle cell patients. So thank you very much for your time.
Good morning now once again. I'm still standing on the existing protocol. I'm still Dr. Collins Madoka. And I'm also the site lead for UATH, University of Abuja Teaching Hospital. UATH is a 520 bedded tertiary institution located in Gwagwalada, Abuja here. Located in Gwagwalada, Abuja here. In our registry, we boast of about 1,680 patients. And our clinic days are basically on Wednesdays and Fridays. For the Wednesday clinic is an afternoon clinic, and a Friday clinic is a morning clinic. And in our staff strengths, we have a dedicated accelerate staff members, and this includes 3 hematologists, including a professor of hematology, a professor of chemical pathology. We have 3 dedicated nurses, a clinical psychologist, and as you know, UATH is a home for all subspecialties in medicine. So for our clinical workflow, usually you start the clinic days with a health talk, because we believe that the physical health is as good as your mental health. This talk borders on psychology, nutrition, and physical health education. And this followed up with videos to ensure that these messages are sent home. Now, after this, we have a virtual medical record where these patients go and register for the day's clinic, and eventually moved in for the nursing care where vital signs are taken, and subsequently they are shifted to the physicians who take history. If the patient is a new patient, we have registrars who take their history. After the detailed history and clinical assessment, they are moved over to the consultant who will assess these patients, decide whether they will need a further laboratory investigation, as these patients usually come in with all expense paid full blood count and urinalysis before seeing the physician. And if they need a further investigation, they are moved over to the laboratory section and subsequently to the pharmacy, and eventually they are allowed to go home. Outside this routine daily clinical activity, we have run a 24-hour emergency services in case any of these patients develop a hematological emergency requiring the attention of a physician. Then for the investigation we offer, being a tertiary center, we offer an all-inclusive investigation bordering on hematological investigations like full blood count and retic counts. We also offer a full biochemical panel involving liver function tests, renal function tests, urinalysis. We also do pregnancy tests and hemoglobin F quantification. I think that's basically that. Thank you very much.
Thank you. Thank you once more. And it's nice to see everybody once again. I wouldn't have recognized some people in this room if I passed them on the main road. We have had several meetings. Adama is laughing. We've had several meetings on several things, but I'm sure if I had met, I would have passed without knowing that was Dr. Ladd. And Emmanuel, again, thank you for making our time to come. At least now we know the person we've been gisting with all along. And Professor Brown, a lot of people, Hassan, Ocha, and a lot of people, Timothy. You know, I only hear him on Zoom. I've never seen him live. So it's good to see everybody here once more. And thank you, Professor Nodu, for providing the platform. The journey has been worthwhile. The journey has been worthwhile. I remember the first meeting we had, I think was here in the University of Virginia, or was it in Top Rank? That was the very first one we had when we were about to start. And I was a bit queasy. I'm asking, are you sure this is going to work? How are we going to pull it, people, when there's no money? But today we are here. And I think then we didn't have any professor. But now, now we have professors all over the room. So the journey has been worthwhile. The journey, and when people see my CV, they ask, how were you able to write all these papers? They don't know it's because of you guys and the collaboration and a lot of things that have been done. So I'm Aziz Emadu. I work with the University of Nigeria Teaching Hospital, Chukwuozala. Well, let me say that with regards to the patient's workflow, the patients come in through at least 3 routes. They can come in through the emergency room, they can come to the clinic, okay, and they can come through the daycare, okay. And the clinic, they can come through referrals as primary patients. So all these routes will have to be factored in. Okay. So when the patients arrive, they go to the medical records where the electronic medical records has to be activated. Then after they've made payment, because if you don't make payment, they won't activate it. So once it's activated, then every other thing comes into play. And they can now go to take their vital signs. After the vital signs, they now see the doctors. While they're waiting to see the doctors, they have health talks, they have their meetings of the warriors. And if anybody is interested in doing any research, that is the time to talk to them, because once they are done and they see their doctor, everybody is on their way out. Okay, so that's when the counseling and they're talking to them and getting consent. And that's at that point that the research assistants have to see them. Then another point to note is that since they are using the electronic medical records, getting data is no longer that easy for anybody who doesn't have a password. So most of the time, if the research assistant is not a staff in the department or in that particular clinic, the research assistant does not have access to the data. So you can't see the patient's laboratory results, you can't see anything. Okay, so the only way if they have the physical printed out copy to get the patient to give it to you when they exit, or the doctor seeing them will have to be part of collecting the data, because it's only the doctors and the nurses that can see the data of each patient. And another thing about this is that unless the patient pays, you will not have access to the patient's data. So it's only on the clinic days that I can see the patient's data for 2 years or 5 years ago. Any other day that I come there, I will not be able to access it. So these are things that we have to put in, especially when it's what comes with the electronic data system. So it's not like the olden days where we can get the folder of everybody and now begin to analyze the folder. Now, they have to pay, or unless there's a way you can talk to the data guys and they give you access. They say they can do that. They give you access to all sickle cell patients, their clinical data on the register. So you can also, because when you are filling the data, you also click the diagnosis. So they can filter out sickle cell patients above 18. They can filter out sickle cell patients below 6 and give you access to all their data. So that's again something that we have to think about. So they see the doctors. After seeing the doctor, then they have to get back to the nurses for the appointment dates, which still have to be written on their physical cards. Then they go ahead straight to the pharmacy and to the laboratory. Nowadays, there's no paper, so they don't carry any paper. So all you need to do is when you go to the lab, you provide your ID, and the lab calls up your ID, and all your lab requests come out. When you go to the pharmacy, you present your ID, and the pharmacy calls up your ID, and all your drugs for that day come out, together with the doses and everything, and they just dispense. Okay, so that is what we do. We have 2 clinic days, pediatric and adults, separate. So the adult hematologists in UNTH, we are 20 adult hematologists. As a matter of fact, if Collins has stayed long enough, he would have been the 21st. We are the only department that has, in Nigeria, I think, that has a hematology, the biggest hematology department, and a hematology consultant in the emergency room that is employed just to man the emergency room. Gladys, she has just been employed. She was a research fellow in SPARC-NET. She wrote one of our research fellows. So she has now been employed. She's an emergency. She stays in the emergency room and handles all hematology emergencies. So nowadays, we don't have to worry too much. So somebody asked, what have you people be giving your CMG that you're able to get all that? So, but with regards to hemoglobinopathies, we have 4 dedicated hematologists that do just hemoglobinopathy only, like myself. We have 4 that do blood transfusion only. They don't go to any other thing. And 4 that do hemostasis only. Okay, so now we're pushing for more. So as I'm here, there are 3 other hematologists at home that run the clinic. So they don't have any serious staff shortfalls when somebody has to go for conferences. Then, next slide, please. So, but for the pediatric hematologists, we have 2 on ground. Dr. Ezenwosu, Professor Ezenwosu, and Professor Chukwu, Bart Chukwu. Unfortunately, two of our older sickle cell hemoglobinopathy pediatric hematologists just retired, Professor Modi and Professor Ikefuna. And both of them retired at once. So it's a big, well, not really a big blow because the young ones are coming up, but they have been there for ages. I think they took over from Professor Kaine, who was there in the 70s and 80s. She ran the sickle cell clinic alone herself before she trained MOD and Ikefuna. So, and the two of them have just retired. So, but we have Ezenwosu and we have Chukwu. Chukwu was trained by SPARC in Brazil. He did a TCD training in Brazil. He was the person that at Sickle Cell Network, Sickle Cell Support sent him to Brazil to do a TCD. So he's also one of us, the spirit. So both of them are people, and Ezenwosu has been working, he's also a research fellow here. So both of them have been working closely with us and have been on the program for some time. So we have a research staff for SPARC. We have one research assistant, and for the accelerate study, we also have another research assistant. Again, unfortunately, many of our older nurses that were trained in sickle cell hemoglobinopathy over the years, most of them have again retired. And we have about 3 dedicated nurses to the sickle cell clinic. And one just told me that the hospital has given her the go-ahead to go for hemoglobinopathy training. So if you know any hemoglobinopathy training going on anywhere, we would like to send 2 of our nurses because it seems the CMD is now, I think they can also support them financially to go for those trainings. So they have been asking us to find out where they can be trained on hemoglobinopathy. We had a nutritionist, but she stopped coming after some time because she said the sickle cell patients were not seeking for her help. So she used to sit idle when she comes. But we're about to get her. I'm trying to locate her again to see whether she can start coming to the clinic. She used to come to give counseling. As a matter of fact, she was doing more counseling than more nutrition work. Okay, so we also have the warrior support group who come on clinic day. Some of them are staff of the hospital, so they just come to hang around and see who is having problems. And maybe some of them also in their WhatsApp group where they are chatting, they know people that have problems that are coming for that particular clinic day. So some of them that are staff come around to help them navigate blood transfusion, help them navigate the daycare and things like that. And they are very, very, very helpful. Very, very helpful. So we don't have any dedicated pharmacy. We use the pharmacy together with the entire hospital. The lab we use is the General Hospital Service Lab, chem parts, hematology, microbiology. But we also have a molecular medicine, molecular diagnostic lab within the department, which also doubles as a research lab. Well, all of us run it, but Professor Opala is we buy the equipment, we bought the equipment piecemeal, all of us with our research grants. And now, not just PCR, the lab can also do hematology analysis and chemistry. Okay? And they can also extract DNA. They can also do PCR, manual PCR. Now, based on our experience with previous laboratory work, we prefer to use this lab. For one reason, it just handles only hematology, our own, or hemoglobinopathy, but hematology generally, our own samples. Those that are, we think, of from indigent patients that can't pay, we run it free of charge for them. But every other patient goes to the hospital pool, okay? And for research samples, we prefer to use this because from our experience, when you send your research sample to the main lab, 40% of your results will get lost because they don't understand research. They think it's service. So they tell you the sample got clotted or call the patient to come back, the sample wasn't good, or that the result wasn't, and nobody flagged it. And after 2 months, they ask you, when you ask them for the full blood count result, they say, call the person, let's resample. You can't find the result. And we find out that a lot of things in the lab give us, cost is the reason why we have incomplete data. So you can imagine if you're running full blood count and electrolytes and everything every 3 months. And after 6 months, you go back and you only have, instead of doing full blood count, the person did PCV. And the electrolytes is incomplete. And these are things that are time bound. And it has passed, it has passed. So at the end of 1 year, out of 100 patients, you only have 30 patients with complete results. The other 70 It's either using day 3 or month 3 full block, and this person doesn't have SUC for month 2. This person, and at the end of the day, makes nonsense of the whole effort everybody has made. So we prefer to use this dedicated system where the people there, the people that work there are not from the hospital, they are research staff that are paid by the grant. And they understand when they say research that data must be complete. Okay. And if there's anything, they flag it immediately so that you rerun the sample while you're still in the clinic, not after 2 weeks. Come to take liver function test and they'll tell you that the sample wasn't enough, so they didn't do bilirubin. And you see, you can't proceed much with that. So we prefer to use this for that reason, okay, and for also the reason that it's also cheaper, because the grant also pays for part of it. Next slide. So that is all, and thank you once more for having me here.
Good morning, everyone. My name is Ijoma Diaku Akinwumi. In Lasus, where I come from, they call me Dr. Akinwumi. But for publication purposes, I put Diaku Akinwumi in honor of a Diaku that was a professor, my father. So I want to first thank Professor Nodu for giving me the opportunity to come on board SPARC out of Sickle Cell Support Society of Nigeria. It's been a very interesting ride, I must say. It's helped me answer a certain prayer to be named when they talk about sickle cell in my state. Thank you. And then I would just like to thank the Accelerate team for this. This is a great resource. The building that was donated to us for sickle cell in pediatrics has a little research room where we have places to put some resources that anybody can walk in and just and anybody can walk in and just read up some landmark studies and stuff like that. And this is a very good resource, particularly the directory of other sickle cell centers are in the SPARC ring, because we often have to send children, in the transition group off to university in some place or the other apart from Lagos. So I usually would want a personal recommendation of a particular service. So the Pediatric Hematology Oncology Unit has 3 consultants, myself and 2, please go on. 3 consultants, myself as lead and 2 other consultants who I trained. One of them is more interested in cancer than sickle cell, and the other one is new and currently floating between the 2. We have to remember she's no longer a resident. So Dr. Mugba, you are there, aren't you? Somewhere. Thank you. So she works really hard, basically like serving 2 separate units that are going full force. And Dr. Mugba is the person who really does some of this research work with me. She's been with us for just a couple of months so far. So we have 3 pediatric nurses and 1 very hardworking general nurse, Ms. Falomo. And then we have an assistant director of administration just for the pediatric sickle cell project, who also has an admin officer and a clerical officer attached to her. They've been very helpful, and the distraction of writing letters to management and all that have been taken off. It was quite tedious. So we have 2 research assistants. One is a research assistant that the Accelerate program has basically engaged, or I have engaged on behalf of the Accelerate program. She's a warrior, and she's very passionate about what we're doing. She's happy about it as well. And then one other person who is a copper, and the coppers tend to come and go, so they fill in the gaps for the research assistants. So I have usually 2 senior registrars. One might go on leave. I think one is starting from today. and then 1 registrar and 2 house officers. We are severely short-staffed. So these residents are not for pediatric sickle cell alone, they are for the pediatric hematology oncology unit. So they have ward duties as well. The pediatric sickle cell center closes about 6:37, depending on what is still pending at 6 o'clock. And so we have a TCD technician who originally started as the RA for Accelerate and then went on to do her core duty and left it for the new RA. And then we have 1 medical laboratory scientist who's trained in sickle cell on their RISE program with me. So she has been posted to the Pediatric Sickle Cell Center's laboratory, and she has with her a medical laboratory technician and phlebotomist. We have 2 pharmacists, one of whom also has done sickle cell training on their RISE program and has been detailed to stay in the pharmacy in the sickle cell center. Next slide, please. Okay. So we also, the hospital is poised to give multidisciplinary care because we have practically every specialty that a sickle cell patient at any age might need in the course of providing multidisciplinary care. We're all there together, we know one another, and getting hold of one of the consultants to either send a senior registrar or come in person is very easy. And so we have full radiological services from interventional radiology through to MRIs and CT scans or regular radiographs or ultrasounds. But they don't do transcranial Doppler ultrasound. That's done in the clinic in the Pediatric Sickle Cell Center. We recently got a donation of a second TCD machine. So now we have 2 TCD machines. So we try to provide TCD. The reason why we got a TCD technician is so that it won't just be me scanning and maybe one of my residents who's. And so we're hoping that we're hoping to ride on the June conference to have a bigger training program where residents in neurology and pediatric neurology and pediatric hematology will be trained, as well as some nursing staff that went with me on their RISE program, who already began to take training for TCD. Professor Penela Kirkham was training them before they came back. So with TCD, actually doing the work is what gives you expertise, really. It's not just that you got trained. I remember nobody wanted to train me when we didn't have a machine, and now I understand. So we have a daycare center that closes at 6:30, like I said. It's got 3 beds, and sometimes we can use the 4th bed that is in the transfusion room for an admission. Next slide. So our services, we have approximately 1,400 patients enrolled and some transitioning, but we also have new patients every clinic to place them, so keeping the numbers approximately stable. And then each week we see between 40 and 55. Occasionally we see an 81 or a 61 once they lost some paper document and just schedule people for appointments without referring to that one, and so we're oversubscribed. So they left clinic at 7:30 that day. I wasn't there, so I escaped that. Okay, so we offer TCD on clinic days. The transport is extremely expensive in Lagos now. Most of the people we see in LASUs are not empowered per se. They're not, some of them, you have to give them transfer money to go home and all sorts of things like that. And they come from really far off because the government keeps, one presenter previously mentioned transferring people who are trained. It's a very bad problem in Lagos State-wide. So I've conducted trainings for sickle cell from newborn through to transition for the Ministry of Health with practically every general hospital. But suddenly I see the patients beginning to come back to me and I'm asking, there's a clinic in your, around your area. Why aren't you using, oh, they've transferred her. So I'm still looking for a way to have the government commit to, training, maybe have regional centers where they won't move the people around so much. Sometimes it's a matter of the doctor knowing how to go about the ministries, what's it called now? Their transfer things and keeping themselves just where they want to be. But everybody doesn't have that privilege. So you need to be maybe like a policy from eventually. Okay, so practically all blood tests that we might need to do are available within LASUS. LASUS runs most of the laboratories are private public partnership arrangements. And next slide, please. We have in-house pharmacy and in-house laboratory. They're not yet fully functional. So what happens really is that the aim of that building is to make sickle cell services in one building, and the patients don't have to go there and pay, then show the receipt there. Then that's what happens. And it makes some people just come late because they leave it till they absolutely have to come to hospital. And it also delays even while patients are being seen and management is being instituted. So clinics are on Thursday, starts about 9:30 a.m. because there's a daily clinical meeting that ends at that time. The patients go to the main pediatrics department where their folders had been retrieved because there's an appointment book. Paper-based, we're a bit behind on our EMR plan. And so they then usher them to the Pediatric Sickle Cell Center, where they sit in a comfortable lobby, unlike our former crowded place. They sit in a comfortable lobby, watch TV. If you can spare our data for the lobbies, we're still working on the internet arrangement for the building, it's a general one. So usually one of the nurses would put up her internet connection for that purpose, and the children will watch cartoons. So Health Information Management Unit have an office where they stay in the building, so they coordinate, making sure that all the records are available for us. So the very next to the lobby is the nurses station, is a room with all the stadiometers and everything. So they take blood pressure, height, weight, temperature, SpO2, and record it on the paper, the file. And then a senior registrar comes to check and separates new cases from follow-up. And the follow-up cases are seen by the senior registrars, while the new cases are clerked fully and presented to a consultant or a senior registrar before all happens, or everything else goes on. So all the doctors get to prescribe and write tests. Next slide, please. While the in-house pharmacy arranges to have the prescription filled. So for responsibilities, especially with the Accelerate program, research assistant is actually the first point of call for the Accelerate people. And then she's done the recruitment of 43, strange number because we were asked to do 42. But we discovered that one of the last few patients that we recruited came from somewhere where she had to pay 12,000 naira to come and go with that child, an adolescent whom she couldn't lap. And in fact, I think we had to send her some money ahead before, or asked her, she couldn't really make it. And we're worried that she will not keep up the whole, and then she doesn't seem like the kind of person that will go out of her way because there's research. So we recruited a 43rd person. So she has basically taken the data from the patient recruited and manages the tab with all the information and red cap and makes the follow-up calls for the clinic. So after that, this is what we plan for the Accelerate. That hasn't happened yet. Measurements haven't been taken. So they will go to the nurses who are implementation facilitators, where they're now going to take all the vital signs and stuff, and some clinical work and counseling. And then the doctors come in and they order tests or interventions, which all the other ancillary staff. Thank you. I think that's about it. Now, people have been seeing it, and I think it might be available on. Okay. The building is, we borrowed land from the Department of Medicine as it were, knocked down one of the male medical wards because we have space constraints, and then put it back and raised 2 levels for pediatric sickle cell just for that purpose. So the first floor level is all the clinical stuff happening there, and then the higher level is a conference hall, a research office, and the consultants' offices upstairs. So we also have dedicated 100 kVA generator. Because I don't like queuing for fuel and writing letters, we asked for solar alternative energy. So we have about 40 kVA of alternative energy, which powers directly and saves for nighttime. We don't do nighttime in pediatrics. So medicine department, our landlords, enjoy that one. All right, thank you very much.
Thank you very much. The next one.
Upper Friday on this. No, Friday on the 28th. Thank you, man. Yeah, good morning, everyone. So my name is Akinyemi Ofakurin. I'm the site PI for the Jos University Teaching Hospital. So I want to start by appreciating the principal investigator, Professor Nodu, for the opportunity given me. Okay, and also Professor Pepra, my teacher. So he has actually been teaching us online. So it's a privilege to see you physically. So you're welcome to Nigeria. So back to what I was actually trying to say, for the opportunity given me to be part of, this great team. So, and since then, she has been mentoring me and giving me responsibilities to ensure that I grow. So I want to say a big thank you to you, man. Thank you very much. So I want to start by saying that Jos University Teaching Hospital is a teaching hospital, a referral hospital in Jos Plateau State, North Central Nigeria. So, and we receive referrals, from all the cities in the state, and as well as neighboring states. So, for instance, the part of Southern Kaduna, they actually receive care from youth, then also some parts of Bauchi State. So we have, we serve different states, not just only Plateau State. So then the pediatric hematology oncology unit, which I run, I'm one of the consultants, we are two there. So I attend to children with sickle cell disease on an inpatient and outpatient basis. So our clinic, well, I'm still going to say more things about that. So we run our clinic every week, and we see an average of 50 to 60 patients per week. Next slide, please. So talking about how we get access to our patients, it's actually either those stable patients coming to the clinic or those in crisis presenting at the emergency room. So I'm going to start with the emergency room presentation. So whenever they come, there's actually the medical records that is attached to the emergency room, not just the general medical record, to make sure that the care we provide to the patients are actually very fast. So, and after sorting out the registration process, so they are promptly seen by the residents that are on call there. So the place is usually covered 24 hours. So then there's also a consultant that's attached to the emergency room as well. So after being seen, the patients are being seen by the resident doctors, then they are reviewed by the consultants. Then at the same time, we, the hematology unit, were invited to come and see the patients, even at the emergency unit. So, and eventually after stabilizing the child, they are transferred to the ward where we take full responsibility for the care of the patients. So then, next slide, I want to talk about the clinic. So for the clinic presentation, we run our clinics every Wednesdays. So that's for the pediatrics. Then we have a good working relationship with the adult hematologist as well. So they run their clinics on Fridays. And this is also important because we have started having some patients that are adults, that, some with transition, some although non-formally, but we are planning to actually have a formal transition care now, so that they run, the adults, they run their clinics on Fridays. So when they come to the clinic, they do the registration. And most importantly, before the consultation will start, there's the aspect of health education that we routinely give them. So that is there that will provide information to them about health maintenance, answer their questions. And, you know, it's usually handled by the nurses and once in a while by the doctors. So part of what I plan to do, because, well, as Professor Inodu actually said, I came back from the UK to have some training, and I spent at least quite a long time. So the plan is that we're going to improve on the health education. At least we have the SPARC book on ground already, so that we make sure that we train the nurses very well. Whatever information that they are delivering is actually authentic information. Because at times, you know, you sit at the where health education is being given, and you discover that some of the information are actually what they thought, not what is evidence-based. So we're going to address that and make sure that everything is sorted. So then thereafter, they are consulted, you know, we have the consultants, then the residents and manage the clinic. Then all our laboratory tests are done in the hospital. So then regarding the laboratory test generally, which I'm still going to talk about that, but I just want to mention something, then when I get to that, I skip that. So we have the hospital laboratory where all investigations are done. Then we also have side laboratory that is attached to pediatrics department. That's for us to be able to get our investigation very fast, so we use that. So for instance, if a patient comes to the clinic and they have some issues, we can quickly tell them, do flublocam, do malaria parasite test, or some other basic test, and we'll review that result before the end of the clinic and provide appropriate treatment. Then likewise, the pharmacy, the hospital pharmacy is actually functional, and they receive their drugs there. So for patients who are not able to afford that, then we'll give them prescription and they go outside to get the drugs wherever they desire. Next slide. So about the staff strength and the patients. So the number of the patients that we see weekly is about 50 to 60. Then the number of patients on our register, we have about 1,300 patients, and we keep the record, and the record keeps on growing every week. So there are 2 consultant pediatricians attached to the pediatrics unit. What I'm presenting now is actually basically pediatrics. For the adult hematology, we have 6 adult hematologists and 5 resident doctors in the hematology unit. So, and part of what I also plan to do is that we have a good working relationship, but for us to consolidate on that so that we can work together better. So from our own end, we have 5 resident doctors at a point attached to the pediatric hematology oncology unit. Then 2 house officers, then we have 2 nurses in the clinic, then 2 research assistants. So for the purpose of the accelerate, as in I have a very hardworking and dedicated research assistant who happens to be my senior registrar that I trained, very hardworking. So for the period that I was away, he was actually doing excellently well, recruiting the patients, you know, I was just interacting, making sure that everything was going on fine and everything went very well. So we've been able to recruit the 42 patients. So, and they've been coming to clinic afterwards. Then we also have 1 psychologist that's from the hospital that, you know, whenever we need their services, they come around to provide care. Then from the lab that I was referring to, the side laboratory. So we have 1 laboratory scientist there, 1 laboratory technician. So this gives us the opportunity to be able to get things done without all the bureaucracy attached to, you know, some, if we're sending it to the main lab. Yes, we send our samples to the main lab, but once we need to take urgent action, so we do that. Then I also want to say that at this point, they're talking about, there are actually some research rooms. Yes, we don't have a dedicated sickle cell building. So, but a research room that the HOD has actually, given to us for us to use. Because when I was leaving, we're talking about that there are some equipment that will be given by the accelerated program, talking about Gazelle machine. So I want to state that a place has been given to us so that we can keep that safely and be able to use that. Yeah. So then we also have very good relationship with the other, as in we have a multidisciplinary team approach, ranging from the pediatric specialist, the pediatric neurologist, cardiologist, endocrinologist, so that, and we've been nutritionist, we'll be managing our patients with them so that whenever there's any problem, we co-manage. And with the little exposure that I had, the way they do the multidisciplinary team clinic, I also want to actually see that we do that in our facility, so that it's not just about sending to them. Even there will be some points that we actually attend to the patient, and it gives a better outcome. So I've passed that information across even while I was away, and it was well received. So this is the time for us to implement that. So then talking about the laboratory tests, we have the basic hematology, biochemical, radiological services, we have CT scan, MRI, ultrasound. I put query TCD. Yes, there's actually an ultrasound machine that we have now, and I learned that there's a probe that can do imaging TCD. So, but in the UK, I was trained on non-imaging TCD. So I'm still looking at how we're going to go about that. So then, okay, we have echocardiography. Then I just want to finally talking about the laboratory state that we're induced. We have genomic lab, that's actually a standard one. Then microbiology, molecular lab. Then there's also APIN lab, which is now incorporated into JUICE, although they are on their own, but the staff there are being paid by JUICE. So they've been working, all these years with Northwestern University, Harvard University, doing a lot of investigations, and they are still doing that. So with any research that we need to do, if we need, sophisticated tests and a very high quality assurance, they are always there for us. So then other things that I want to say is about the good working relationship with the adult hematology, which we plan now that we're going to have a formal transitional care, transitional care clinic, so that we can improve on our relationship with them, so that even we can do more things. And this is also important in the sense that some of those of our patients that are actually recruited on the SPARC, some of them are adults that will transition, so that if we have a good working relationship with them, we can still monitor them and make sure that everything is fine with them. So finally, I want to state also that we have Sickle Cell Warriors WhatsApp group. It's actually a group of adolescents and adults, about 75 of them, although some few ones actually died, so that they're there. And they invited me to the WhatsApp group, so that it's actually an avenue, to give them health education, to pull them together, so that their care will actually be optimized. And they've also been supportive in the aspect of research. So I want to say a big thank you once again for the opportunity given me. So thank you very much.
So let me begin by saying that my name is Dr. Okocha Ifechukudi, and I am the site lead for Nnamdi Azikiwe University Teaching Hospital. I'd like to quickly say that we are family. Indeed, we are. And I'm really glad to see all your faces again. It's been quite a while.
In fact, when Professor Petra Emmanuel began to speak, I immediately recognized the voice. Yeah, but I didn't recognize the face. So it shows that we have been away for quite a while. So I'm just going to be the bottom pot, they say, in Africa, to the last person to speak. So what we have by way of clinic days is actually Tuesday for adults, and then Wednesdays for pediatrics. So we were in a small hospital before, maybe like 400 beds, but now we have transitioned to a mega city hospital, thousands. But then it's still in transition. So what we have is not, we are just, as in a way, patching, trying to do the best we can till everything opens up. Things are still being built, buildings are still going up, and so many things. So we are not there, not quite there yet. So however, we are by way of our workflow, we normally will get referrals from everywhere. We cover not just Anambra State, we'll cover Delta State and some of the other states around us too. So when people come to our clinic, we get referrals from these places, and we can do self-referrals also. And sometimes for the emergencies, they come to the ER, the emergency room, and then they are seen there. They call our residents to see, we see and admit into the ward. So for the clinics, normally we would have the patients who go with their, will come to us in the clinic. We will refer them to now go to the medical records. We just note on their, they bring a paper, we write that they should go to the medical records, and they take that paper to the medical records, and the medical records will register them and put them into the electronic system. They now go to the nurses to take the vital signs, to take the height, the weight. And then when they finish with that, their names get into our system, and then they stay and wait. Normally, we would entertain them. We used to give snacks and we used to give drinks. That was bad. When one bottle of water is now 250, one bottle of malt is now 600, and we are unable, because of funding, to do what we used to do. But we will still get there, I hope and I pray. So while they are waiting, our research assistants will now come and interview them and take their data. And they would, for what they cannot feel because it's clinically oriented, they will wait till they see the doctor. And when they are seeing the doctors help them to feel those parts. But some of our research assistants are quite good because they have been on the job for quite a while. You find that even what you think it's a doctor that will do, they are able to do. So that's one good thing in having someone stay for some time. So some of the things we want to note about what the research assistants will do is that they will take the patient and register the patient into our own WhatsApp group. So again, the theme there is that we're a family. We want to be a family. The WhatsApp group is a family of warriors. Our doctors are also there. And when they do that, we are able to reach them. Now, also they put the patients in the red cap system. They do that. They have been trained to do that. And then we also have our own records. They also put them in our own records. So we have close to 500 patients, if not more, that are in our records now. So the good thing about putting everyone on a WhatsApp group is that family theme that we have. We are able to keep up with them wherever they are. We know, even when they leave the confines of our geographical location and go to somewhere else, we're able to reach them through the WhatsApp group. If we have a situation where we need to call them for something, we're able to reach them. So that's very important to us, and we do our best to make sure that that is kept on. However, and of course, we form them into a sickle cell club. We have a president, we have an executive, and then from time to time, when we need to do anything, the executive of the club will go on to see what they can do. But a big problem we have is a stigmatization. It's a stigma. So in fact, the president, who is still serving, told me he couldn't really do so much because he just got married. And he hasn't even told his in-laws that he has sickle cell disease. So he doesn't want to come to the radio program and a few other things. And in fact, this has been such a problem that we had to encourage people by writing a poem about it. This poem, because of time, we can't read it, but I have put it on our own WhatsApp platform. You can read the poem for yourself on that WhatsApp platform. So we have a radio program too. We had to move that radio program from a weekday to Saturday so that our own people can listen in and also ask questions. And we not only talk about our own people. This radio program involves the whole nation. We take people from other sites and work with them to educate and to bring people who are stakeholders to teach and say many things about what we are doing. The radio program, apart from radio program, which is just like once in a month, we try to do other things to also keep up the education. So we run jingles also from time to time. In fact, these jingles can run every day while they're having their news and other programs. So we also keep people going with that, with the jingles that we have. So follow-up is important to us. And we try to make as many people come for follow-up. Now, what we do, two things we do actually, we call them. But because funding is limited, we're unable to make as many calls as we want. So what we then do is to message them by WhatsApp. So on the general WhatsApp platform, we put a message. If you have not seen us for 3 months, please come and see this doctor. I put my name or another person's name and team the next clinic. And some of them respond. But we will also like to add their calling to that. We also have some other sickle cell clubs that are not our own. In fact, we have like maybe, let's say 2. And this is a place where they are a huge group. There are places where if we need to bring people in for to intervene, drug trials, any kind of trial, these are some of the places where we reach out to and they come in their numbers. As many as you want will come. Okay, so those are the highlights for the research assistant and the group that we have. So our doctors normally will see and then do tests. Most of the tests are available in our hospitals. The routine tests we do are packed cell volume and urine analysis, and then every other test that is necessary for that particular patient. We normally will walk the patient up for hydroxyurea. Every patient gets walked up for hydroxyurea. The test we don't have is hemoglobin F. So we have to send them outside the hospital to do that. But again, one of the challenges we have is that even when we have walked up for hydroxyurea, commenced hydroxyurea, they are unable to continue. Sometimes because of complications, many more times because they are unable to fund. They are buying hydroxyurea themselves. So when this Accelerate program came up, it was really, how do we say, a round peg in a round hole. It was just done right. So then if they need to be referred to other specialists, they will also be able to do that. We do that in our clinic. So we generally have a team of multidisciplinary staff and consultants looking after our patients. What we want to do is to transition this team to people who are dedicated, because right now they are not dedicated. But we have people we are working with. Whenever we need to do anything that has to do with sickle cell disease, we call them in. But we would like to now reach out to them to say, we want to dedicate you. So anybody we are sending to the pediatric, to the surgeons for orthopedic, we know we'll send to this particular consultant. And the same for every other thing that we need to send out. So by way of staff, we have 6 hematologists, 4 senior registrars, and 2 registrars working with us. We are short-staffed, but we do the best that we can. Now, what are the things we would like to do going forward that we don't have or we have in mind to do? So we would like to have a dedicated team of members. That I have already said that. So we will also like a dedicated clinic for sickle cell disease, because right now we don't have one. It's just a general clinic for all hematology patients. We would like to have this so that we can have a complex, like some of us do, where everything you want to do, you can do in that complex. That would be a wonderful thing for us. Then we will also like a daycare center. We don't have one now, but we'd like to get one. Then we would like to put the patient on insurance. Some insurance, insurance is available. The state has an insurance platform. I think the federal government also has an insurance platform. But to go and do the work, see, this is where now this stigma and the executive, they fail. If I need to go and pursue and do the work myself, I will have to leave my job. That's not acceptable for those people who have employed me. It is the group, the executive that should actually do this, but because of stigma, it's difficult to push them to go and do what they ought to do. So we are still finding a way to see how we can get this done. I think, and yes, I talked about other sickle cell clubs. I think that's all I have to say for now.
Okay, just like Collins, my name still remains Tayo Ajayoba. So to Professor Okocha's point on insurance, what we did here in Accelerate and with the UATH SCD program was that we wrote to the FCT HIS, Health Insurance Scheme, and we asked them that we have people on our registry, and that they should please accept them into the Basic Healthcare Provision Fund. So that's a fund for vulnerable people, and they graciously accepted. So we took the people on the registry from UATH Adults, UATH Pediatrics, from National Hospital and Yanya General Hospital. And we got forms for them to fill. They filled the forms, they attached their documentation, and then we took that to FHIS. So they're in the background, so to say. Now the health insurance scheme calls them because they need to assign them to specific primary healthcare centers, which are closest to them. So first they call to confirm that they are actually vulnerable people, and then 2, they call to confirm their location so that they can place them. They said in Abuja they had 20,000 spaces available, enrollments. So far, we've been able to enroll 501, I think, through our program. And they are going through all of the states to do that. Your state is Anambra, Prof. I'm told that Anambra has one of the best programs for health insurance. And we heard this from FCT Health Insurance because they actually came to understudy the insurance in that place. So I think maybe one way you can help to bridge it and all of us is actually to do a letter of your warriors, right? Do a letter concerning your warriors to the health insurance scheme, and they can help them. Now, the basic healthcare provision fund doesn't cover everything, right? But it covers a lot of services for them. And it's particularly for those who are indigent, it's a great lifesaver for them. Now, if you go to the package that is paid for 13,500 per person, it covers a little bit more of those services. But for 13,500, I think for those ones, you probably have access to hydroxyurEa. A lot of the facilities don't stock because of prices and all of those things. But you can help them actually if you do write a letter, and then there in the background, you write the letter, and then through your services, just to be sure it's the warriors. And that's how we did it in Abuja so far. You have a question? Yes. Okay. Very good point. They need to be referred. Yes. Yes, the health centers here also refer, because for many of them, they're not as resourced as they should be. And a lot of the patients actually will maybe prefer that, right? But what it does is that because you are registered in a facility, what the insurance pays to that facility covers your service, right? So they get the referral and they still come to teaching hospitals or the secondary level hospitals in some of the instances. I think part of what SPARC was going to do was to, or I think it's the federal ministry, to move care to devolve care. So I'm sure Prof will speak to that.
So the policy of government for NCDs, unfortunately, they're having a meeting, a very important meeting at this same time that we're here on NCD, the policies and then the strategic plan of action. So what the government has intended is for NCD care to be devolved to primary healthcare centers. So these primary healthcare centers, as you're hearing, are going to be revamped, they are going to be repositioned, and that is where the patients want to go. The patients don't want to come to us. You understand? It's closer to them with, all the challenges and the difficulties, the transport and all of that. So we want to, as SPARC, one of the things that we want to do in the next iteration is to train those primary healthcare centers to do basic care, standard basic care. And we have the standard of care guideline for that level. So we want to target those healthcare workers. We've actually started doing a little bit of it, but we want to do more so that wherever our patients are enrolled, in those places, we'll train them using the SPARC standard of care guideline for that level. And I think we can do the same. The resources are online, you understand, and then we can arrange and do that, because I believe that our teaching hospitals should be like referral centers, and we have outposts. Each site should have 1 or 2 or 3 primary healthcare centers that you're nurturing and bringing along. For us, we have a number of those primary healthcare centers here in Gwagwalada. One of it is Gwagwalada Town Clinic, and we actually want to start a sickle cell health maintenance clinic in that place because there are enough of them. So this is where the government is going, and we have to go along with the government. Thank you.
I think we need to energize ourselves a little. Maybe we stand up and greet somebody, at least for the blood system to recirculate. Yeah. Oh, I told them to move around. Okay. So that blood will recirculate. Greet somebody. Well done. Are we ready? Okay. Okay. Yes. Okay. I think we have exercised ourselves, and I'm sure everybody must have greeted somebody. Let's have our seats so that we can proceed. Okay. Are we together? Are we together? Can we proceed? Okay. Only moderate. Okay. I think the next thing on the agenda is review of the study protocol. I'm sure everybody will agree with me that for us to move into the implementation stage of this accelerate research, the basics is knowing the protocol. because without the protocol, there's nothing much we can do. But with the protocol, the work becomes easier for everybody. My role is to moderate, and it's my pleasure to welcome the people who will take us through a review of the protocol. In the person of the principal investigators, it's my pleasure to welcome Mr. Emmanuel Pepra as part of the discussants for the review of the study protocol. And Professor Obiageli Nodru, who will be going through the protocol. I think we have to choose how to go about it. I'm sure there are a lot of questions from people on this protocol, a lot of clarifications, and some areas or gaps we need to bridge for us to proceed to the next stage. Be that as it, I'm sure most people have gone through it, have an idea of what questions to ask. But we want to start by having an overview from the principal investigators while we jot down our questions. The questions basically is to help us make it more practical in our respective sites, because we are going to be the people seeing the patients or organizing those seeing the patients. So let's listen to them on the overview of the study protocol, write down our questions and areas of clarification. I think with that, I want to call on Professor Nodru. Okay, Professor Emmanuel Pepra to give us an overview of the protocol. You're highly welcome.
Thank you so much for that introduction. And as stated, we are going to give an overview of the protocol, and then I ask that you hold your questions until the end. Part of this two-day session is that we'll first start with the overview, and then we'll have actual in-depth training. So there are going to be some things that you might want to ask, but we can get more into it. Now, some sites are going to be in the intervention arm. Some sites are going to be in the intervention arm. I have to stand here. I like to walk and talk, so I'll try my best to stand here. So some sites are going to be in the intervention arm, and they will have a separate set of training, and then other sites will be in the control arm. So this is a pragmatic cluster randomized clinical implementation trial. So basically what that means is that nobody is blinded. You know if you're in the intervention arm and you know you're in the control arm. In most clinical trials, there is blinding, right? So people in the intervention arm or people in the control arm, they don't necessarily know which arm they are in. Because we're doing a pragmatic trial under real world conditions, we're not trying to control for everything. We're trying to understand contextually, how can we improve provider adoption of hydroxyurEa, and what are the barriers and facilitators of that? So that's generally the overall, and we're using an implementation science framework, which I'll go through a little bit, but I ask that you hold your questions, and as we go through the sessions today and tomorrow, please engage, ask your questions. We'll also go through the study forms, so that if there are any questions about the study forms, any clarifications, or even any suggestions of how we can improve those, we're more than happy to welcome and try and make those adaptations as needed, so that when we move forward into the actual clinical trial, everybody's on the same page, everybody understands, and there are no questions. So thank you so much. So can we move to the next slide? So as everybody knows, this is the Accelerate team. Everybody should be up here. We are here because of Professor Nodru and everything she's done, because of that significant SPARC-NEt establishment in terms of all these particular sites. So everybody up here, everybody should be up here, and if not, please let us know. But I think Prof has done a wonderful job highlighting the significant work that has been done to put together the registry. And it is that registry that actually formed the foundation for this particular work. So we were able to show to the National Institutes of Health that we had an existing population that was in a registry, and we could do this work in terms of having a cluster randomized trial in terms of 20 sites. Now, because of logistical challenges, we're going down to 16. Next slide. So these are sort of the primary objectives of the Accelerate program. And I said it's an implementation science program. So in addition, so there are two parts to this study. We are actually going to be giving, as US provider, we'll be giving patients hydroxyurea. And then we're going to also be collecting laboratory measures to see how those patients are doing on hydroxyurea. We know that hydroxyurea is an evidence-based intervention. There are over 15 published studies. And of the latest trial, the REACH trial that was done in over 3 or 4 sub-Saharan African countries, show that hydroxyurea is effective. So in this particular trial, we're not trying to show the effectiveness of hydroxyurea, because we know if you take it for sickle cell disease management, you're going to improve. But we also need to know that if you're taking it, of course, we have to make sure that you're actively monitored via clinical laboratory monitoring. But our secondary objective is to make sure that our patients are doing well. It would be unethical for us to give a drug and then not check on the significance of the patients in terms of their health, right? So, but our primary objective is, because it's an implementation trial, a pragmatic trial, we're looking at adoption, as Prof stated previously, in terms of the work that we had done before submitting this grant. We saw that there was some provider maybe reluctance in terms of prescribing hydroxyurea based on cost, as had been mentioned, and based on some perceptions in terms of it. Our training is designed to really address those issues in terms of any sort of provider reluctance, because ultimately, in order for patients to have hydroxyurea, the providers have to assess the patients and see that they're willing to first prescribe that hydroxyurea. The second thing is cost. So in terms of implementation outcomes, because cost was a significant barrier, we wanted to address that and make sure that the control arm and also the experimental arm, there were no differences in terms of cost. So as one of the things that we told the NIH, we were going to provide hydroxyurea as free for these patients. So to lower that bar in terms of, if a physician feels that their patients should be on hydroxyurea, they do not have to worry about whether the patient can basically pay for it or not, because that was one of those issues that came up in our qualitative work that we did in terms of it. And then the secondary objectives are, of course, looking at our intervention, right? And seeing whether our intervention is adapted or adopted, looking at the fidelity of the intervention. Was it implemented the same way within all the different sites, or was it implemented a little bit differently, and documenting those particular differences? So for example, if a site has patients and let's say only 50% of those patients are on hydroxyurea, what happened at that particular site compared to a site that 90% of those patients are on hydroxyurea? We know that it's not because of cost, because of course we're providing hydroxyurea for free. So it could be other factors. And we're going to collect that data. We're going to collect a lot of qualitative and quantitative data to help us to understand sort of what's going on and then try and address those. Next slide. So these are the specific aims. You have them. I'm not going to go over them in terms of it. Just a few things. There is an implementation science framework called EBIs, which stands for exploration, preparation, implementation, and sustainment. And I can talk more about that. But for the purposes of this discussion, to talk about the overall protocol, we're not going to talk about that, but we'll talk about some of the other things. Next slide. And this overall is the design and overview. So this is a 2-arm cluster randomized pragmatic trial. Basically, nobody's blinded. So basically everybody kind of knows where they are. And we have the top arm, which is the intervention arm. Individuals within clusters within or sites within this arm will of course receive the SIM training. Everybody will receive that. And then those sites will have also the TOX TCP or the implementation strategy, which is 2 parts. That is the healthcare training. That's what the T stands for. Oh, thank you. So that is the health clinical reminders. That's where the C stands for, and the practice facilitation. So we will have individuals that are going to be at the intervention arm, helping in terms of asking any questions that people might have, physicians or even nurses might have in terms of sickle cell disease. For the control arm, everybody gets SIM in terms of it, and then for the control individual, they will not get that TOSH TCP, which is our implementation training, but they will receive all the materials in terms of it, and then we'll decide. Our simple hypothesis will increase greater adoption of the screen, initiate, and maintenance hydroxyurEa at the sites randomized to the intervention arm compared to the sites that are only in the control arm. So we believe that this implementation strategy is going to be effective. Now, that's our hypothesis. That does not necessarily bear itself out. There are several other situations that could happen. So, for example, if the materials are so good that individuals at the control arm start to adopt those possibilities, we might not see any difference in adoption between these two arms, which is great. What does that tell us? That tells us that our training materials are so well that we don't really need an implementation, right? Or we could have an issue with which want to see greater adoption, but we won't see greater adoption. And what's that situation? That situation would mean probably we didn't do something right in our training, right? In terms of providing that level of assistance, maybe the practice facilitation. So because this is a cluster randomized pragmatic trial, we don't know all these answers, but this is our hypothesis, and we'll see what the data bears out in about 2 to 3 years, or so, in about 3 years or so. So we don't have any conclusions as of yet. We have theories, we'll collect data, and then we'll see what happens in terms of at the end of these 3 years. Next. So this is the EBIs concept in terms of the implementation framework. And usually, so this EBIs is in 4 phases. The exploration stands for E, the preparation stands for T, the implementation phase, and the post-implementation phase, or the sustaining. Right now, we are at the preparation phase, because we are preparing to implement our implementation process at this point. So we've done the exploration, which we did in year 2. Now we're in year 1. Now we're in year 2, and we're going to be moving into year 3 and 4. Year 3 and 4 are when we actually do our pragmatic implementation. And then, of course, we'll look at sustainment. Sustainment is after 12 years of active practice facilitation in the intervention arm, will healthcare providers continue to basically operate in that mode, even if there is no practice facilitation. So there's adoption drop after those things. What we're doing is we're actually collecting data every 6 months. So we make sure that we're not trying to be overburdensome in terms of our data collection. There's some clinical trials that collect data every 3 months, but actually they're only collecting at baseline, 6 months, 12 months, 24 months, and 48. So we're collecting it for 2 years, total 6-month increments. So we hope that that will not be a burden as we will take through planning this trial. Next slide. This is the study design, and we'll just, and this is what I covered. We have right, that are randomized, the intervention strategy, sites that are randomized to the control strategy. Next slide. Everybody knows this map. The beautiful map of where all the 16 sites are. Next slide. And here's our study timeline. So this is our 2-year. So here's our exploration and preparation phase that I discussed. And then this is our implementation phase. And then year 5, we'll do a lot of the data analysis and start the publication of all these findings course, individuals that are involved in this, you'll be on those publications when we start to get them out. Your site needs, your investigators in this whole thing. Next slide. So first thing is the protocol that we're going to discuss. A high-level protocol has been published. We were able to publish that earlier this year. So it's in the scientific domain. This is freely available for you to download. We're happy to share with you if you want. We can send you an email and actually attach the file to it. So our protocol is number one out there. So I'm going to be covering it. So in terms of our protocol, these are, as I've discussed, sort of our aim. So this is actually what is called a mixed method study. We're collecting both quantitative data, clinical outcomes data, which all of you are familiar with, right? Pain pricing, et cetera, all of those, and also qualitative data. As part of this process, we're going to be talking to you as providers in terms of thinking through sort of what the training that you've done, and also ask you to answer some questions. That qualitative data is going to add to the quantitative data. Quantitative data can tell us a lot of things in terms of how patients are doing, and in terms of patient outcomes, but whether something is working or not, we can sort of figure it out based on, the number of people who have adopted it, but why people adopted it versus why people didn't adopt it. That's what we get from qualitative data. You're not going to get that from quantitative data. So that's why this is a mixed method study. We believe that both the quantitative and the qualitative data will give us a holistic view of what's going on. Maybe some things that we didn't think about when we were putting this grant together. And in many ways, sometimes when we put these grants together, there's some things that we don't really think about and we don't really occur to us until we collect the data, and we've had great focus group discussions. So as part of this, we'll be doing focus group discussions, individual level interviews with all of you in terms of getting your opinion, because you have the expertise today in terms of it. What we're trying to do is just figure out if we can help you have better adoption of the hydroxyurEa. And at the end, as I said, I showed you both the intervention arm and the control arm. Our hypothesis is that we think the implementation strategy will increase because based on our previous work in Ghana using a similar implementation strategy for hypertension management, it showed that we were actually able to decrease blood. So we believe the implementation strategy works, and we know that it works clinically, it has been validated for hypertension. We don't know if that's going to work. And this is what we're doing. So a primary outcome is basically adoption right here, and then our secondary aim is sustainability. So this is sustainable. So the first year of the trial is going to be active facilitation within the intervention arm. The second year, we're not going to have active facilitation because this is basically a behavior change strategy, right? If you're doing something for a year, it should be hopefully ingrained in terms of behavior. However, if we draw that away, are you still going to be able to follow through in terms of that behavior? Adoption increases, then maybe there's something else we need to work on. But again, that qualitative data will help us. Next slide. So primary outcomes, of course, adoption. Secondary outcomes, sustainability, 24 months. So after the first 12 months, there will be the sustainability rate. And I'm happy to that. Next slide. All right, so study medication. I don't have to talk to you all about hydroxyurEa. I think everybody in this group knows very well about hydroxyurEa, but we know that there can be some adverse side effects from hydroxyurEa. So that's why we need the laboratory monitoring in terms of it. We're putting a lot of people on hydroxyurEa at the same time at the 16 different ICU. And that is actually one of our secondary outcomes. Because if we think about it, if we can show that our training was effective and we have clinical data to show that people actually sickle cell disease patients actually improve on hydroxyurea, which we believe they will, then we have a training modality. The importance of that training modality is simply this. Nigeria is the most populous country in Africa. It has the largest percentage of individuals with sickle cell. However, Nigeria is not the only country with individuals with sickle cell. I'm from Ghana. We have individuals with sickle cell disease living in Ghana. We have folks in the DRC. We have so many other countries that have patients with sickle cell disease. None of those countries, as far as I know, has a training regimen of how to really train providers to really administer hydroxyurea, train, initiate, and maintain those. As far as we know, that's why this is the grant. This grant is the first grant to do that. So what we find here in Nigeria can be very important in terms of the Nigerian context and thinking about how we train the individual to really administer hydroxyurea in an evidence-based effective manner. But more so, because there are patients outside of Nigeria, this can be also transformative. What we find here is applicable in Ghana, it's applicable in DRC, it's applicable in basically any country that has large sickle cell disease population. So that's the importance of this problem, right? So that we can find a modality that can really increase adoption of this outcome in terms of hydroxyurea uptake, then it's applicable in so many different settings. So that is really the importance of this. And it can be, I believe, transformation. But we have to do the work and figure out if our training is actually effective or not, right? All right, next one. So the description of the intervention. So I went through and sort of described at the high level the two arms of it in terms of everything. But it's the things about training. In the grant, we wrote that it might be 2 hours for physician training. We don't know, we'll figure it out, right? And then we said it might be maybe 4 hours, or it might be 4 hours with physician training. And then other skills and staff training. We're still working on those things, right? So we don't have the specific number, but it's not going to be a 2 hour session where we sit down and you're training. It's going to be a few minutes here and so on and so forth. And then you're going to also have booster training as we improve. So these are some of the things, number one, we're here to talk to you about, and then we'll have to think through how we can implement some of these things. Next slide. So patients, as you stated, in both arms will receive hydroxyurea. So we're not going to discriminate based on whether a person can pay or not. We're going to leave that judgment to you all in terms of position, whether a patient should be on hydroxyurea. And sometimes there's some patients that probably shouldn't be on hydroxyurea, but that should be your own judgment. And that will be based on the context, but we want to make sure that cost is something that you do not have to worry about, at least for those leaders in terms of, right? Next. I've already discussed the simplest group, which is the experimental arm. That's more intense in terms of practice facilitation, clinical reminders, and training. So those sites randomized to the experimental arm will have some modules in which they'll have to do in addition to on-site. Then the intervention arm, of course, you'll receive all the materials, etc., in terms of training, but you will not have that active practice facilitator at your site. And next, laboratory monitoring. Of course, laboratory monitoring will be one of the important aspects of this. I think that everybody knows and appreciates that. Next slide. And then, of course, this is, as I stated, the pragmatic cluster randomized implementation problem. So, cluster randomized implementation problem. And what we're doing is, of course, we'll collect data on the clinical effectiveness of hydroxyurea. But again, our main outcome is going to be, of course, adoption, sustainability, fidelity, or implementation. Next slide.
So for this 2-day session, this is a high-level overview. We're also going to talk about the case report forms here, and our colleagues, Ruben, Joyce, and John will lead that session. We're going to talk about the pre-training evaluation. That's what we'll lead that. And then, of course, the sim training, which we'll provide here, which is Professor Brown and myself will lead that session. Next. And then, of course, in terms of after the breakout, we're going to have 2 groups, right? This will happen after lunch. So intervention arm will go into one room where they will talk about all the intervention in terms of practice facilitation, the training, etc. All of those things will occur, and they'll have significant training on that. In terms of the control arm, we'll talk about sort of some of the challenges in terms of the facilitation of the screen, initiate, and maintenance issues. And then last but not least, we talk about the post-training evaluation. So this is what we're going to do today. I'm here to answer any questions in terms of this sort of high-level overview, but as stated, after lunch, we'll get more in-depth in terms of talking about the protocol, also the patient report form, and you might have, any suggestions you might have in terms of it. And we'll have a great discussion, and hopefully, I think this is a great group, so we'll have a lively conversation in terms of how everything is happening. I'm really truly excited about meeting everybody. We sort of met online and met previously, but I'm really truly excited. I think that if we are able to do this in a way that can get us in good solid results, it can be very comfortable. So right now, if you have any questions, I'm more than happy to answer those questions and then make it great. Yes.
Is those groups will get hydroxyurEa.
Yes.
Those groups will also get material that will educate. So the only difference is that one group will get facilitators,
right,
and the other group will not.
Right.
What is the difference?
So that's a great question. Can you go back to the last level context? Go back. Right. Thank you. So that's okay. So the intervention arm will actually have 3 things. They'll get follow training. So there'll be follow training and module after the initial training. We'll ask that individual and that intervention arm to also take part in it. They'll have clinical reminders, sort of what are the reminders that are important. The practice participation aspect will be, are there any issues in terms of management or in terms of the administration of hydroxyurEa that clients might have? Those facilities will be able to sort of be providing or mention about that. We cannot assume that everybody's going to be expert. Everybody here, in terms of being the site PI, are experts in terms of it. But in terms of everybody at your site, in terms of managing the sickle cell disease, we cannot assume that they have the expertise that you do, correct? Or should we make that assumption? But you can't assume. Correct. So those facilitators will be there in terms of other hematologists or other non-hematologist physicians if they have questions. If they feel that they can come to you, but they also have other resources. But you might be busy. In terms of thinking about you as being site PI, you're very, very busy in your time. And sometimes if a physician is taking care of a patient and might have a question, they might not be able to come to you. But it's very important that we think about those facilitators should have some time so that if somebody has a question, they can reach them and be able to answer the question. Because Dr. Coach, I know you're busy, but John, where you see that? So that is the idea behind that. Yes. Right. Right. And see how, if I'm not wrong, let me reiterate what I think I understand from people. This is a 5-year project. 1 to 3 are already done. Year 1 and 2. Year 1 and 2 are we're going to year 3. So year 3, where you now split the sites into 2 arms. Correct. The first arm, depending on your site, either in the front or in the intervention to experimental. Because the intervention that is why they work actually in the same. But you know which intervention, 3 aspects. You have practice application, working at the side. You also have typical reminders, I give it's for people that are volunteers that are already included. You get a reminders. Then the healthcare workers will be trained on hydroxyurEa for the 1 year period starting from about next month. And some additional booster training. Okay. So after the next 1 year, while the other sites will not get any, or maybe they'll just get educational materials which they are giving for patients to be known, the doctors to share, and the hospital and everybody to share. Then after that 1 year and some period after, all this will end. And we will now go another 1 year of following up on the patients to see whether what we did in the 1 year prospectively from now has changed their adoption or use of hydroxyurEa. So that is where the focus group discussions and the interviews and other things will come in, but not. So you're partly correct, but we're also going to be assessing providers in terms of thinking about have they changed in terms of their behavior, prescription or screening or anything else. So this is actually a provider level intervention. So we're collecting 2 types of data. We're collecting patient level data and we're collecting provider level data. Because it's important that we know what your providers think, what has influenced you in terms of your adoption. So a year in terms of this is a long time, but after that practice facilitation has ended, that changed your perspective, right? If you feel that that practice facilitation was important. So in implementation, we call that the sustainment phase. So when you withdraw that support that you initially did to see if that behavior sort of embedded itself and is it able to sustain. If it's not been able to sustain, then we need to think maybe our implementation strategy was not the right strategy. So it could be after this 1 year at the top, and we have another 12, so the first 12 months, and then from 12 to 24 months, maybe many of those things that we thought we provided support for was not sustainable, and we will be able to detect that at that year mark or after those. Yeah.
So for practice, so we approach the practice and we ask for the growth. Because basically we don't have enough money to do the study, get the growth. And so they asked me just now, what do we want? Do you want capsules or tablets?
Yeah, tablets, tablets, because you can break that approach.
Because of the tablets, you need to be able to break. So then, you know, they are going through internal discussions. I believe that maybe for them, there are some things they can donate and some things they cannot donate. You have to buy. So they just said, let me tell them what we want. I said, anyone you give us, I mean, it's okay, but assuming that we have the choice, we would rather have tablets, right? But if we ask for tablets and it's not the one that they are donating, isn't it better to say whichever one it is? Yes. We will prefer tablets.
But if you don't have, if you
I
don't
knew
have,
that.
there are tablets I need. So the point about them, let's start with mindful.
So we just want the drug.
Yes, we just want to drug.
Well, before we consider, Prof, I have a question on the drug issue, because the research talks about sustainment. I know Novartis is a branded company with costly medications. If we give Novartis, do we continue with Novartis for them at the end of the whole program? They can always change to another brand. Okay.
So I'm just wondering if you and affordable in the long term, there's no problem with that.
So, but there are some grants, that you get. You may not be getting the expected results, just like in my center, there are some grants you give to some patients, you get results. There are some grants you give, you will not get the results here. So if we're using different brand for the study and then a different brand to continue after the study, you should also take that one.
So, if they say they won't give us money for the capsules, let's ask them what strengths they have. The challenge in pediatrics is that you want smaller doses, okay? Very often we need to mix, combine hydroxyurEa capsule 500 milligram with 200 milligram, or 200 milligram again, 800 milligram. So if all they have is 500 milligram, and to be useless for children. Because when the pharmacists compound them to make them syrup, the shelf life is short. So if they can't give us tabs because the tabs are new and they want to, give out the older stuff with capsule, let us know what strength of capsule they have. Or if they can mix smaller strengths along with the bigger strength so that we can combine them and conveniently to give to children.
If they can give us time, they can give us capsules mixed strength, 500 milligram, 250 milligram, 100 if they have. And what we want is to be able to optimize the dosing for the children.
What I want to is continue that's one of the prevention is going to have a plan for how we going to just yes. Because by using a medium, then you can't say we are using 100 milligrams just to get unless we're going to say so. Because the grades for the child and I'm trying to say that if you say that let's say 20 minutes for some children to fall in between we're going to
Yes, I see that because I've asked them and they don't have an answer. What is this table? Are we doing it or they have some other solution? Because this is the kind of thing that somebody can say, oh, technology and wants to get to. It's not a good thing. And you deal with what are you doing with it? We give it, and some of them have 20 milligrams per kilogram, some of them have 22, depending on rounding it up to what it is. Just the same. That's what it is. So, because I know they were supposed to be training for how to use it. That's what. No, I know that there's information. What I'm trying to say is if you have the tablet, sorry, if you have tracks, even that, but for something we are trying to succeed, we need to actually have enough practical instructions for all the whole work. That is all implementation science research education.
So you're saying for the 2 years, you're arguing that for the 2 years. I think Cornelia has done a fantastic job getting the artists on board and getting to this point. So I would say this, I don't have any hesitation about the sustainment for the artists providing what is available for 2 years. If they tell us they cannot, then that's a conversation. But as far as I know,
your point right, and I would like us not to talk to Novartis at this point. On our own, please do not talk to Novartis. We are discussing with Novartis global. Please don't talk to Novartis Nigeria. Let us get this drug first. Because if they don't give us this drug, we cannot do this stuff. Thank you.
So, my questions are two. One is, after this year, we are going to be looking at change in prescription behavior doctors in those hands. So what happens if in my center I have a policy which is prescribe hydroxyurEa for everyone? That's one question. So the other question is, we're also going to be looking at change of behavior for our patients. And we're going to stop giving them the drug after this year. Is it after 1 year?
No, after 2 years, but I think you talked about possibly other mechanisms and that kind of insurance scheme and some of these other things. But that is, I think, let me just first answer your question. Now let me take the second. The first question is prescribing behavior, correct? What if there is a policy? So if there is a policy that says everybody with sickle cell gets hydroxyurEa, then that's something we have to know, because again, we're talking about real world randomized pragmatic trial. So you have to adhere to that policy. We will document it within our specific network to say that for this particular center, there was a policy implemented. So the adoption rates are 100%. We know it's a policy. However, there's a new policy and you're still getting 80% adoption. We know that not everybody's following that policy. Our thing is to really make sure that we take note of those policies or those changes. However, by no means is this trial supposed to circumvent your own clinical judgment about how you manage your patient. What we're trying to do is give you some tools, you want your center, some tools in which you can how to do that more effectively. Again, we do not know if what we're doing will be effective. We know that the drug is evidence-based, and we know that if individuals are on that drug, then they should have better outcomes. You're absolutely right in terms of patients. So in terms of the laboratory monitoring, we'll see. Patient can say, I'm taking hydroxyurEa. Go to the lab, you don't know, where hematocrit and everything else shows that they're probably so there's ways to validate those things. But what we're trying to do is document all of these things and report it. And we're not trying to specifically make any particular judgment on whether policy is right or policy is wrong. Ultimately, we are concerned about is this training against is this training going to increase provider level adoption of hydroxyurEa within a particular center, within the center, specifically for the intervention arm compared to those in
when are we stopping hydroxyurEa for the patients?
I
think the question is centered on protocol. The protocol. That's the session we have. I'm sure there will be time for the hydroxyurEa discussion. So let's concentrate on the protocol. So that we be on time. So if you have a question on protocol, please participate and ask your questions.
Okay, thank you, Emmanuel. I think the forms that we have already on our salaries are those that we needed for the pre-assessment, I guess. But I think majority of the pre-assessments, if not all, were for the patients or the enrollees, people that have been enrolled. I was wondering because I'm seeing more forms here. And to be able to capture the question that Professor Kocha was asking, is there going to be a form that we have to fill to correct the information from the providers and the institutions before we start, so that after some time we can do a post and see whether their views have changed? Because I'm going back, I see from 8B, from 8A, and a lot of other forms that we're supposed to complete from here. So I'm wondering at what point they begin to come into play. So the blue, you'll see this chart right here, which shows when the forms are supposed to be administered. So most of the forms are baseline, like you said, and then you see 6 months, 12 months, 18 months, and 24 months. So there's some form, for example, form 1, that's only used at baseline, that is not anywhere else. So if you have questions about when you're supposed to use these forms, I would urge you to refer to this chart right here, which can be very, very helpful. And these forms will be available via also. But we will do a deeper dive into the form in terms of looking at seeing if there are any questions, comments, or general suggestions about how we can make them a little bit more clear or anything like that. But this guy right here will provide, and I want to really just putting together a great everything that we need.
Still have at least 15 minutes to conclude this session.
Okay, the Gantt chart you showed us, Emmanuel, from 7 to the forms from 7 to 11, and some like 8E, 8F, 8G. I don't think we filled them yet at baseline. Are we going to fill them now after this meeting when we get back? Or is it the people in the intervention arm that filled them?
So right now it's not a baseline. This is just a meeting for us, and we're going to do a deeper dive. Once we start officially, then we will let everybody know. This is baseline. So remember, we're collecting at 6 months and 12 months, right? You cannot start officially until has given the word, the green light, which means everything from Novartis and all of our, we have everything done, make sure that everything is good to go. All the sites are ready to finish our recruitment.
we still have a couple of things that we need to do from recruitment. So there are several things, a couple of months at least, in terms of to make sure that everybody's up to speed before we can get started. Once we get started, you know, the green line will be pleased. And we'll send out a reminder in terms of getting this form, you know, but you have actually hard to say and those moments supposed to be. But please, you know, those moments will have something to fix. Okay, because this is not this. Other person.
There's just a comment he called my attention to from the online participants. So medication form will be administered and we will see changes in prescription practice over time.
Yes, hello, good morning. This is Joyce Gemfi here.
Joyce, okay.
Yes, so there was a question regarding how are we able to notice the changes in prescription over time? And for that, we have a medication form, right? So that will allow us to see the changes in prescription practice. And we can dive deeper into it when we go over the study forms. Does that help?
So the George is saying that we have a form assessing changes in the is that correct?
Yes, that is correct.
Great, great. All right. So yes, so we thought about a lot of these forms. And again, we'll do a deeper dive in terms of this. Again, our thing is our attempt is to try and assess both quantitative and qualitative anything that might cause a change in adoption or that use of adoption, interest in adoption. Again, our hypothesis is there, we'll be able to get approved with, but we need that evidence after the and again, we'll do a deeper dive into the forms, and I think other questions will come up during that time. So please feel free when we're having a discussion. I think now is the time before we start in a few months to really clear up any sort of questions you might have, or comments that you might have today. And we're open to having this dialogue.
Yeah. My question is, how do you assess adoption for patients?
So you assess adoption for patients. You can assess adoption several ways. One of the ways that you can assess adoption is you can look at the number of prescribers that prescribe. All of these individuals will be hydroxyurEa naive, right? So they're not on hydroxyurEa. So you can look at, for your census, in those 50 patients or so, how many of them, given their sound medical judgment, should be on hydroxyurEa, right? So we have prescription, we're going to document that. And how many of those patients go and get that hydroxyurEa? So that's the first one, right? We have laboratory monitoring to show that they're on hydroxyurEa. And then over time, how many of those also maintain the hydroxyurEa that they're on? So we can assess that. How many were prescribed? How many actually got hydroxyurEa? How many also maintain that? But that's more of adherence and not adoption. Adoption is when we're talking about adoption at the provider level, you're saying this is the evidence-based intervention. You have been trained to do it. Are you still going to do it and maintain it? So that is what we're talking about. So when you're talking about patients, we have to really sort of differentiate a little bit between adherence, and then when we're talking about providers, we have to really determine between adoption.
Are the ones providing these drugs. We write, we provide. The patient will just take it, and there is not adopting it by a choice. We are giving it to him or her.
So we're going to help you to one taking the drug and whether or not go on to that stage of things.
Prof has a question.
Thank you. My response the fact that they said we are giving the drug and everybody will take. I don't think that is the process. We've actually enrolled a certain number of people. When the hydroxyurEa is available, we discuss with them that this drug is available and it's free. Are you willing to take it? If someone declines, you cannot force it. So it's not that it's automatic, they must take. So that should be clarified.
That's it.
The new test of whether this thing is sustainable isn't better observed when we stop.
Training in terms of provider level training show that providers will adopt it. Based on our initial work, we saw that there was hesitancy. So you have a very important question. However, we're not necessarily designed to address that question because we are at the provider level, but we're also looking at provider level options and patient level options because it's the issues around hyper. But very good.
That's why I wanted to ask. Because since we know the drugs is available, except I don't want to prescribe. One measure for sustainability is increase. I know the drug is available at the pharmacy, I will prescribe. So when we stop giving free drugs, then you can actually measure that because I will now look at the patient and say, okay, right, I think this person can afford it, go back, or I want to prescribe because I see this patient may not be able to afford it and all that factors. But as far as I know, the drugs are available at the pharmacy and it's free, I will prescribe. So you always see the increased prescription. That's what I think.
Yeah, I agree. The question is, will you see those increase for those 2 years?
Let me just say something. I think it's important that we understand that the study design is aimed at assessing the impact of the intervention. The intervention is not providing free hydroxyurEa. That's where we are getting it from, because both those in the control arm will still get free hydroxyurEa. You can give me a drug free and I take it home and I won't take it. So what we are really assessing is the impact of those 3 strategies, which is healthcare provider training, critical reminders, and using practice facilitation. Even within the 1 year that it is free, is there going to be a difference in how many people that actually take the hydroxyurEa that you've given them, one hospital from another? Then after the 1 year, a lot of us, does it even increase as time goes on, even those for those without intervention compared to those that don't have that intervention? Then at the end of 1 year, when you stopped
and you're still giving them hydroxyurea free, but you're no longer reminding them using reminders, and the facilitator doesn't come to the clinic again to chide them, play with them, and remind them, are they going to still continue taking that hydroxyurea, even though you're giving it free for both again? So I think the control arm nullifies the free drug because the control sites still get their free drug anyway. So that's why we have that control. So I think it's important that we get the answer.
Thank you. I just want to add that when this whole accelerator started, I was a bit confused until we started the implementation course. That was when it became quite clear to me. So the key thing I learned, this accelerator is for providers, not for the patient. And in our clinical practice, like where I come from, we realize some of our colleagues don't prescribe because they have their own reasons for not. So that is what this project is targeting, reminding them, training them, facilitating. So it's got nothing to do with the patient, it's to change our own attitude to see with all this TCP, is it going to change how we prescribe? So that's, I think, the key message I learned from AstraZeneca. That's why even with both arms have got hydroxyurea, but we need to, because there's so many factors influencing the provider not to prescribe hydroxyurea. So that's what the TCP is meant to see whether it can change and see whether it can increase the uptake. So that's my own contribution.
That's lovely. Thanks. Anything else?
I think we have discussed a lot on this issue. I don't know whether we still have any questions, but it's very stimulating. You can understand that the questions are coming because even with the series of meetings and engagements we've been having, we have improved on our own basic knowledge on hydroxyurea prescription at baseline, because I can tell you for free that there are certain things I didn't know before. But when I started some of all these trainings, I got to know more. So that one is even a positive as it may be. And this program is packed, it's soft packed. We are just starting. And I'm sure as you go to the nitty-gritty of the other thematic areas of this program, we're going to be more enlightened, and some of the questions will be clarified. So I want to say a very big thank you to Dr. Emmanuel Pepra for giving us this interesting lecture. It was quite impressive. So thank you very much. I think we move to the next. Okay, it's still great. It's not one it's still great. All right.
Again, there's asking what are the factors leading to prescribing hydroxyurEa from the healthcare provider perspective. Going back to the visual around what is the purpose of this intervention, it is really at the provider level. For those who are in the detached TCP intervention, did the intervention make an impact when we measure these things from baseline to the different follow-up months. And then finally, when we think about within, again, healthcare providers, about adoption, implementation fidelity, sustainability, scalability, those are all questions that we ask around patient science to our conversation around
is this working and is this sustainable beyond the scope of the grant? We're trying to ask those questions, not at baseline, but during the 1 year mark at 12 months and 2 year mark at 24 months to really understand the perspective. Are there any questions for the healthcare advice?
What information that was designed purely for adults between purely
So 6A has both adult and child patients. And then we can get into the specifics. So all the forms are provided in the next tab 8. And we can review that each format at a time, depending on what's in today. But we do focus maybe as much as for both adults and children.
that answers some of your questions. Form 1 is I will refer to only adults only adult participants. Those have not been there that refers to a child or an adolescent.
For Form 1, this would be for any participant. So if the participant is a child, then we would put the information over here.
The variables to bring attention to that. For instance, participants in non-name neighborhood property. If you check from page 2 of that same form, that is please for children, that it shows that that form is meant for both children and adults. Gives different ages from less than 5 years to 20. But maybe that person said, so an order is like this for consent, they put consent giving or not giving. And I think assets ought to have been there if they are making of the 1 for 1.
So as an example, I think I hear your question, where we might have to change the forms to designate which parts, if it is a child. So as an example, for Form 1, page 1, we can include where it says consented, right? That would be the consent of the parents for their child, right? And of course, when it comes to assent or assent with that child, right? Yes. And then participant name and address, that's fine. But when you go to page 2 of Form 1, so as an example for sociodemographic characteristics, we could ask age because we do have we could indicate when a child is less than 18 years old. But then when it comes to highest educational level attained, same thing, right? So perhaps it's their primary school, perhaps they're in high school. We can still fill those questions out for that. But a question such as, are you currently single, married, or living with a partner? I'm assuming that for children, we will either omit that question or put
because for ease of analysis, we don't need more than 1 or 2 variables, and we just state from the beginning whether this form is being applied to the child or the informant, the participant is an adult. When that is with that variable is inserted and is clear, then you know that every response here refers to the child, or every response refers to the analysis and to the analysis. That's on the other hand, to modify the view of the person that is from how old is your child? How old is your wall? How will you know that you are prepared to go using abilities or something like that? I'm not sure what I'm
If I'm understanding you correctly, it sounds like some of the questions for participants in Form 1 may not be applicable to children. So we create a separate form to indicate that the participant is a child and or participant is an adult. Is that?
You may not need a new form. This one is a very good form. I'm always sending somewhere to state it is a child, but if there was a form, it's a very good form. When you add up variable, this is a child, or the parent's child, is the patient an adult, or it's a child who was thinking about the child, that will have to know what patient is coming from.
So probably the first question will be selected as child, or, and I'm curious, will there ever be a situation where both the parent and child would be told as a parent with living with sickle cell disease and their child?
Yeah.
Is that possible?
Yeah,
Teacher points. Okay. But to indicate that, right, to the point of the first question for Form 1, Page 1 would be indicate if this is a child or adult. This microphone, please. Thank you.
I'm just wondering that if we can modify the consent section, it can take care of this. Here they said consented or refused. If we can then add parental, consent for an adult or child, consent given by parent or caregiver. So once we see that, we know whether you're the child, parental comes or then accent. So in the same area, you can have accent from a child who's 8 years old, parental or caregiver as consent, then adult consent. So if you read that, we need to know now whether you, and then we go to the age and we know whether you're the child.
That is an important point that we should include, but it will not take care of everything. Because we know that for young children, even for older children, the parental consent is given. The assent is also given. Children 7 years and above. About so, but you will add what she has said, but you still important to specify that this consent is being made. Or otherwise, if you have an analysis, you need to check the age of the child, check the consent, and check multiple things to be sure.
Prof, we understand your point. I think what you're trying to do is just do a high-level overview, and then tomorrow we can do the specific edits and suggestions. But your point is well taken. So I'm going to ask if you don't have any questions, that we move on to just and then tomorrow we'll do a deeper dive specifically, and then we can make some specific notes. Sounds good.
I think, sorry, let me just comment. We've actually used these documents here. We've used this for close to the initial development. And there's a consent and assent form that comes before this form 1.
Yes.
So I think it captures the consent that, because this is not the first form. And all of them are pinned together. In the pack we got, you didn't get a pack like this. You pin for every person, one participant, you pin all their forms together. So the first form on this is actually the consent and assent form, which captures it. Then what I realized, because for most of the patients, I enrolled like half of the patients, is that for children, there are questions that once you get through that first part, the other pages you just mark not NA, not admissible, and like how many children do you have, how many you have a wife or husband. For a child, pediatric is straightforward. So you almost skip to the next form. I think it's for the ease of collation of everybody's data that they didn't want to put a lot of things and that we start subdividing the forms into different forms. That's why simple form is being adopted for everybody. Because like if you ask a 5-year-old, when did you start smoking?
If you see a child and say, the child doesn't smoke, it's unconscious, children smoke, but if the child doesn't smoke, then the next question is, for how long have you been smoking? I mean, the next question is already taken for granted. Somebody that has never taken alcohol, and asking you for how many years have you been taking alcohol? The question doesn't make sense.
And when we built that in, we built in skip logics into it, so that if the beginning form before form 1 is that this is a child ascent, we know that there are some things that will naturally be skipped. And so the nice thing about REDCap and Drew will cover this is that everything is within REDCap. So once you click on certain components of it, it will take you to the right question, to your point. Right. So to go back to the timeline on tab 7, the final forms, which are in orange, are the supervisor forms. Again, these are for the practice facilitators and supervisors. Because we do want to understand, this asks about the implementation leadership scale. When we say climate scale, meaning the change within your individual clinics. So again, we ask that baseline and all the different time points to really understand it has the training. This is again a provider level training around TASH TCP. Has it made an impact? We're asking those 3 different levels: patients, providers, and supervisors. And those are the set points.
Observation. Your form 7 has only one question. I'm wondering whether it's actually a questionnaire or it should be a focus group discussion. Yes. Form 7, there's only one question. How many years have you been practicing sickle cell disease care? And that ends Form 7.
No, so Form 7 should have a full focus group guide.
Okay, so the other parts that will be added eventually, right?
Right. Also, keep in mind that the focus group discussion guide is that the focus group is led by us, the Accelerate research team. So the providers are not holding the focus group. We as the research team are part of that group. So the form that you see in your binders, that's for you as the participant and the focus group to fill out. And then what we do in the focus group, I think tomorrow in the Sickle meeting, would be for us at you, the providers, your thoughts on the implementation of question. Other questions on forms?
My request
for this evening is that you look through the forms. Tomorrow during the stakeholder meeting, we have 2 hours set aside to go through the questions in the forms. If there are questions that we need to change or edit or to clarify, again, these are your the providers in your clinics asking these forms to patients. If you feel that we need to clarify something or change something, please make note of that. As you can see, there's a lot of forms to go through. We will not be able to do that in 2 hours tomorrow. So please take a look tonight and Barb is also discussed.
Thank you very much. Taking us to the CRF. The CRF came as a big pile of forms that were quite daunting, but hopefully online participants have their concerns addressed. Otherwise, when tomorrow comes, there'll be more. Is there anybody that is online who is asking questions about the CRF? Do you have any? Hello? Do you have any asking questions? Okay, so I presume that their concerns have been addressed. So we're going over the forms from Form 1 all the way to 11.
7 is not depicted on the chart, but it's one page. And Dr. Pepper has taken note of the form number 7 being scanty and the things that were suggested to be added, and that it might be updated eventually. So we've seen, we need to take note of the fact that the baseline, some of the work for the baseline has been done. We've recruited the patients and we have some participant information, but measurements and laboratory tests have not been done. So that will start when all the medications and things required for all other processes are available. And then it's important to note that the activities in the green boxes are for the patients, and the ones in the blue boxes are focused on providers. And then there's a need for everybody to go through the forms so that at tomorrow's session, we'll be able to ask questions and make sure that all our concerns have been addressed adequately. Because after this implementation workshop, it is a goal. Once they tell us it's time to go, there may not be room to answer the questions in this manner again. So please take time out to go through all the forms and note your questions for tomorrow. Thank you very much. I think the next thing is going so I'm going to hand over to Mr. Ruben is going to take us through a demo that addresses data integrity.
Absolutely, everyone. I'm very excited to check up this mistake. So it's going through this yes. Yes, I was saying that I'm very excited to see some of us again after a very long time. And it was a question of saying that I don't know what this. And I say it's because I'm the single group now. Yes. So I'm so excited to see all of you. You're welcome to our project. By no means, I'm not making any training. I'm not going to train my professors on data integrity. But following what we've seen so far on our data database, it's important we can point out or highlighting things that will help us manage these projects. And we went through this presentation. He mentioned a lot of 1, 2, 3, 4, 5, 6, 7. And people wondering, there's so much forms, how do we manage it? So part of what I'm going to be discussing is how RedCap will help us know these forms. But during those basics, you can just simply use forms. So all those forms, right? When you come, what RedCap does is you take this 1, 2, 3, 4, 5, and then use it for those, take these 3, 4, 5, 6, 7, use it for the next visit. So that's it. Then for data integrity, I will just simply talk about yeah. So for data integrity, I will just talk about some really important things, including logins, access, so that some of those errors that we see at the back end of that red card, we don't see them anymore. We don't waste the time cleaning the data, going back to it to ask you how did you come about these values? So we designed the red card, and I want to really appreciate the Joyce team from NYU for doing very well on the red card. If you look at the red card, it's properly defined and it's scheduled a baseline, and the 6 months and so on. So I want to really appreciate them for doing it. But my job was just to put it on our own server, and we started using it. We've not really before on red card. For me, type of job. And we're all guilty. Many of us want to go not into the red card. So the research assistants all like for those who are the training, this will be easy to understand. And then we can have other training some other times to help understand how to manage that scheduling. So for data integrity, it's important that we know that if we properly enter this data, it is strong planning reproducible in large outcome, prevent data error, ensure compliance with ethical and regulatory standards. Some of the challenges of data integrity that we see includes human error and error in data entry. Some people will put a child, maybe you record that the child is 3 years, and then the height of the child will be 170 centimeters. Those kind of errors, and there is a system. If you don't really talk to them, they don't know, they'll just simply put one thing and then they move ahead. So it's important that we keep on emphasizing correctness of data information into the red card database. The API should log in once in a while, take one record ID, open it, and see, what the research assistants are entering. Then we also experience system failures, like the server. Currently, we are hosting our red card University of Abuja database server, and we also back up on the same cloud server. In any situation where this server, gets, let's say, bad or is destroyed or something, it's not likely possible. And we know our data. Then unauthorized access. I noticed that some site allow their research assistants to use the login information to data. It's important to make sure that if they use your login, your red tab is recorded there. It shows that it is you who entered the data. It is you who made the error. So when we research assistant that accesses to monitor data entry, then inconsistent scheduling, and that's why we're doing about issue. We noticed in during the enrollment part that people started filling forms that supposed to be done at 6 months. Yeah, so we had to clean them. So if you go back for those that we completely deleted those forms. For instance, there are some forms, for instance, food.counts. So some sites filled those information. They are PCB, RBC, those values are already in the database. So we clean them up because at that time, you're supposed to enter it. So what scheduling actually does is to tell you those forms that you need to fill at any particular point in time. So I'm just quickly going to the red card scheduling. Just few slides, and then I'll go to our red card database and also show us just blue things and outdoor. Yeah, so we know that red card is a secure web-based application for data collection, and then it helps manage participant building and follow. So benefits of using RedCap scheduling includes automated reminders for study visits and data entry deadlines. So unlike the previous database that we use for the SPARC-NEt program, this one will now remind. Sorry, let me highlight this first. So this one will remind you that this person's visits, because you are the one that will schedule that patient. So on day one of the patient's visits, you not schedule the patient for maybe baseline visit, 6-month visit, and so on and so forth. So it keeps on reminding you through email or whatever drugs that you selected that this patient's visit is due. Then you follow up to make sure that the patient comes. Because I'm sure all of them will start the same day, and we're not expecting that they should be visiting the hospital on the same day. So as they come, we schedule them, and then they take their medication. So that's part of what the medical scheduling will do. Integration with email and SMS notification. For now, I think the email works fine. So if you use the email prompts, if you work, I just highlighted is thinking at the points where you schedule the patient. So if you go into the RedCap, this is what the RedCap looks like for those of us who have gone in before. The study is accelerated study. It has all the forms, and then on the left-hand side, you will see the scheduling parts that we have incorporated in this story. So when you click on it, and as I'm going to show in the next after these slides, then we'll see how it works. So please, at the time being, it's important to do that should be scheduled for subsequent visits so that you'll be able to monitor. And it, of course, if you do it properly, you get a calendar. Now see all patients with 17021, whatever, is supposed to come on the 7th of April 2025, and then the next visit is in November 2025. Will help you do information. Yeah. So I will just quickly go to, yeah, I think that this is just to be saying what I've said before. I'll just stop this slide and go to RedCap. Okay, so this is our live project. Our RedCap is in adoption status, meaning that this project is live, and all the data here are credible data information. So I'll just show us exactly what I'm saying. If you look at this left-hand side, see the scheduling here. If you select it, it brings you to this it brings you to this section where you can see create schedule or view and edit schedule. So you can create new schedule by selecting the patient that you want to. Yeah, so before I go ahead, please, you will notice that some sites have 1716 and some sites have 1715, 1705, and these are suggestions for each site has a little group. So we have data access group and UAT is the data access group. All the AI, the data there will see only data in that. So if you select the patients you want to schedule for, assuming 171612, then you select the start date and then you generate the schedule. So let me select this. So if you look at the prompt that just came up after selecting that patient, the start date is what you just selected, and then the baseline days, the 6 month visit, the 12 months visit, the 18 months and 24 months, you can schedule for that patient, and then you close. So as the patient visits you, you can do the schedule, choose the dates. These are dates here. You can put time if you want. If your clinic starts by 10 o'clock, you can put 10 a.m., 12 noon, evening. Then you can choose the dates that you want for this baseline visit for that patient. And then if it's on Sunday, you can change it. So yeah, if after 6 months on the calculation or the calendar, the 6 months day is a Saturday or a Sunday, you can move it to a Monday and then select the proper day. And then after that, you move to 6 months, 18 months, and 24 months, based on what you want or how you want or what the protocol says that the patient should come to the clinic. I don't know if that makes sense, but that's all I have to concern share. If you have questions now, to promote things, the proper training will here. No, so if you schedule, there's an email prompt to you. RedCap sends you. Yes. No, not the patient, you. Yeah. Yeah.
Thank you. If I understand you correctly, we're supposed to be scheduling for each patient's household.
Yes, each site.
So as you see a patient, after removing right now, the feedback line, you know how to schedule the person for all the appointments for the entire study, and then see it and use. Am I right?
So yes, the research assistant should do that through your link. You will instruct the person in what to do. The research assistant may not know how long what is expected. But if you tell him, okay, what should we expect you to do? Each patient that we're having 10 visits, these 10 patients are coming. Schedule them for this day, this day. You check the calendar and then you schedule them. That's what we expect. So many research assistants may be able to do that, and if they are not, to guide them to be able to schedule. They won't just assume any day and start scheduling the patients. You have to invite them, and then when they come, you do the rest of the schedule. But it's okay if you can do it before the visit, knowing that they will come on that Wednesday or on that Tuesday.
It's very control of disease. So remember when that's supposed to come. That's good. But I want us to still remember good old hardcore on that particular day they're doing. If possible, we should record instead of the hardcore, because we had an issue in our center where most of the data was not retrieved. We were only taught that we did it in hardcore. That's why the research assistant was able to bring the build data. So if such a thing happens, what do we do? So I still think we can consider doing it in both ways. Direct spread out inputs and maybe a backup platform to avoid, because if the research assistant feels the threat pattern and there's a mistake, we may not be able to recall those back. So let's make that also very easy.
Yeah, so the mistakes are actually minimal. I didn't get that one.
Yeah, that's correct.
of the enrolled patients in the system. So if someone that's she communicated with you or somebody. Okay, that's Dr. Gilechi, yes? Yes, okay, because about the situation. Initially, was showing University of Abuja, but I changed FNCK, all the previous results. We were only not because we did a hardcore, that's why we were able to do first. So I was wondering, as when we did direct on the red card, it means you have to start afresh. Yeah, so that's strange because I mean, red card app doesn't use data. Unless you lose your server, the red card though, it is so reliable. So I don't know if the staff was able to save what he or she has been entering. Because if you do, in my experience with red card, I've not seen anywhere the data that has been saved on red card is deleted. It's a very secure, very standard. Well, how the staff like to say that she said it's very normal that it's one argument is that she was referring under University of Abuja. Then when they changed FMCK, we could not see any of previous recorded data. But in order to mitigate that, I'm still saying that the hard copy helps us. So even in the scheduling, as she do that soft copy direct record, we will still tell her to do hard copy. But there are one or two things she cannot be conscious enough as at that time to do some of those savings. You understand? And make that mistake. Then the good thing is that hard platform copy really gives deadlines in the system. And I agree. Yeah, I think you comment that. Yeah, that's what I wanted to show. Yes, that's what I wanted to show here. That the, I mean, if you log in and you see data from your sets, that is what we have on the access groups. So for EBIs, you have Professor Hassan and Wadara Rangi, I think. Yes. So these are the people on that space. You can't see any other data in any other sites, apart from the fact that you're working in CESTA and you're working in the red card scene and you need the data. So I can't even find it. So it was in USH, the number will be here. And you see UATH adult of 8 and UATH pediatrics for 3. So I believe that she's still learning the red card. So it's struggling, I understand. So I'm not arguing that she did not do the work. I'm just saying that once you're able to save this data on red card, it's safe. Yeah. Yeah. Okay. Yeah. That's all. Thank you very much. Yes.
Thank you very much. So we just had some refresher course, no matter how short it was, and as a group, if it helped, so it's important for us to understand there's a secure system. It's online, but if you are able to save and all that, or you do some work online, you can offline, then you can still upload online when the system comes online. Okay, it's important that the maybe but if we put in some effort to cross-check what's being filled for us. So especially those of us who have had to change our arrays once or even twice. And remember that when the arrays use your login details, you are held responsible for whatever happens there. Red card characteristically has the information you put on red card is gated, and only people who are authorized in each institution will be granted access when they log into certain information that they are authorized to see. Then he's just giving us a tip about scheduling appointments for the accelerate visit. you have to initiate scheduling the appointment. When you schedule the appointment, you will send reminders to the provider and not to the patient. So sending reminders to the patient, that lies on us, that depends on us to make sure that all that we need to do is done at the right time. And remember that the prompts are just at the 6 months, 12 months, 18 months, and 2 years, 24 months that are on the timing schedule, just so that we can keep to the timing schedule and nobody spoils the study. And then when you don't forget that when you schedule an appointment, just like I've been waiting 6 months, you might look on the calendar and see it falls on the weekend. So if it falls on a weekend, you need to shift it and put it on an appropriate weekday when the patient can actually see. So that's a benefit of having a calendar displayed when you choose the appointment. And then when you choose the appointment or before, they're supposed to indicate whether you want SMS reminders or email. Be sure the email is working. I guess when people choose SMS later on, we'll know how good the SMS is. I would recommend the email because we know how SMSs sometimes get sent and they don't get delivered for hours or a day or two because of network issues around them. So I also want to remind us to make sure that we said we should make sure we save as we go, so you don't lose data. If you manage to save, no matter what setback you have, the data will be on the system. Thank you very, very much. Thank you.
Thank you so much. So what the next is supposed to be launched and pre-evaluation, some pre-evaluation before the same training. So we just had I want to hear from the house. Will we take the next section before we go for lunch? So this you can send to you on WhatsApp your ability test for the same training. All of us are supposed to be part of the same training before we now separate. Yes, on the WhatsApp. You can check the WhatsApp. You see it. So if you have your research assistant, it's forward, yes, to just the person. You want to put it on the whole platform because there are a lot of other people there who are not part of the training. If you didn't get, I know the research. Yes. On your WhatsApp. It's individual, we send it individually, not to the accelerated platform. I did for the majority of people. Yes, I did. Okay. Yes, please.
Affiliation. Let's see what we'll check. So we can do the
Um, okay. Good afternoon once again. So we're moving on to the next session, which is SIM training. Actually, complaining on that, I don't hear it. So the next session is on SIM training, and SIM stands for Screen, Initiate, Maintain, Intervention. I think this training is very important, and that is why we've had a pre-evaluation test before the training. And it's so important because the SIM aspect underpins the implementation strategy for Accelerate. So it's very, very important that we pay attention and note down any question or clarification that we have during the course of the training. We're going to have about 45 to 1 hour for this session, and I'm going to invite Professor Biobele Brown and Dr. Emmanuel Pepra to come and lead us through this session. Thank you.
So thank you so much in terms of it. As has been stated, SIM is the underlying sort of intervention, and then the TOS TCP is the implementation strategy. Here, we're going to go over the SIM, but I think that in terms of SIM, what you're going to see is something that you're going to be really doing already in the clinical setting in terms of both arms. The only thing we're adding to it is the intervention and the sort of the other component in terms of practice facilitation, the clinical reminders, etc., and also those sort of short courses which we'll introduce when we start that intervention as refresher as needed. So that's right. Okay, so what I'm going to be communicating here, which is many of the concepts that you already know. So I think my slide will maybe 10 slides or so, and I'm happy to answer questions as we go. So Accelerate in and of itself is conceived as a task sharing intervention. What is basically task sharing? We're going to cover that, why it's important, and what tasks you believe can be shifted for sickle cell disease management within your particular clinical setting. Now, the other thing is that this is also a pragmatic, cluster randomized clinical implementation/clinical trial. So we are trying to do this in a real world setting. So in terms of what you want to shift to other people within your particular setting, that is up to you. We're not going to be prescriptive and say this is what you should do. What we want to do is document what you have done in terms of the task sharing strategy, which helps you better manage your patient and see if that is definitely leading to better outcomes. So we'll collect that data on there. Again, our level of analysis at the provider level in terms of whether they're screening, initiating, and maintaining hydroxyurea. So basically screening for sickle cell disease, initiate hydroxyurea based on the patient, and then also maintain it over the course of those 2 years. Okay, next slide. So task sharing is basically, and we're happy to share these slides with you. It's basically a rational way of distributing specific duties from physicians to non-physicians. So for example, in terms of thinking about sickle cell disease, there are a lot of things that the physician does that might not necessarily, the physician might not need to do. So for example, following up on patients, the physician needs to prescribe the hydroxyurea, but in terms of following up on patients, if the patient is well maintained, that might be something that can be shifted to maybe a nurse or somebody that's well trained within your setting. However, if the patient is having issues, then again, that might be something that requires a physician level intervention. That is up to you in terms of your setting to think about what is the most proper way to sort of view this whole thing. Now, in some places, you might decide that you might not want to do task sharing as much given the capacity there. But that is up to you, and we'll have to sort of document it in terms of how we do things, because at the end of the day, we want to be able to at least analyze and both qualitatively and quantitatively assess what's going on between different sites and between the intervention arm versus the control arm. So we're going to have, we could have intercluster variability and also intersite variability. So for example, sites, there are 8 sites within the intervention arm. There might be some variability there, which we're likely to see. And then there might be some variability between, of course, the intervention and the control arm. Those are things that we want to document. Now, task sharing is a specific sort of modality that has been utilized in several different cases. Has been utilized in HIV, specifically the task sharing sort of product that we're using comes from Ghana, which was developed by Dr. Digby over at NYU. So he used that strategy in terms of managing hypertension in Ghana, and he showed that there were some great results. And in fact, he's also used that strategy in another funded grant, the Lagos, looking at task sharing to manage hypertension in individuals living with HIV. So overall, in terms of thinking about the task sharing strategy that we utilize, is a strong evidence base for it, that it is very effective in terms of next slide. So we know that in terms of thinking about task sharing, we think that it could be helpful because know that everybody here is very, very busy in terms of being the site EBIs for your particular sites. You have a lot of duty. So the question becomes sort of what is the best way to get some of these things done, right? And honestly, I don't have an answer to that, but I do know that if you think through it, but you can really distribute some of these things, some of these lower tasks in terms of patient follow-up, patient management to other individuals. And that's what we're suggesting that you do and utilize within this concept of the SIM. but we want to make sure that we document those critical things in terms of what you're doing within your site. Okay, next slide. So what are some of the things that can be sort of given to other individuals, maybe nurses, etc. Some of the things that, you already do, patient screening. So most physicians delegate patient screening. And in fact, in the SIM process, the screening part has really already been done, right? So in terms of recruitment, you've already screened for these patients. In terms of sickle cell disease, they've been recruited and they are now within the specific Ruben showed specific site within, and you've entered them into the REDCap database. So you screened at that level, right? So that has already been done. The other two things are the initiate and the maintain. But in terms of screening, we can also think about, we know that these have already been diagnosed with sickle cell disease. What things can we initiate? Also do in terms of cancer. So drug initiation and follow-up. We know that those things in terms of follow, if the patient labs are fine, then it's probably time they can see a nurse instead of a physician each time. But again, that's up to you based on sort of your entire process. And I think that it was very, very helpful this morning to see the different clinical flows that each site uses. And thinking about how some of those clinical flows in terms of the clinical workflows could be augmented might be one way to think about task sharing. So for example, I know a couple of sites stated that once a patient comes in, they usually have their labs and everything there. So they are asked to do labs maybe a day or so ahead before they actually come see the physician. If that's the case, and if their labs are fine and they're doing well in terms of everything else, maybe the follow-up might not necessarily be at the physician level, and it could be followed up. And they might just need to be a follow-up with a physician maybe once a year or something like that, long as they're maintaining their hydroxyurEa and their outcomes are fine. So again, that's it. Patient self-management counseling, that's usually delegated to other individuals, but documenting that if they're a pain or management, pain management, documenting those and thinking about where that layer of follow-up should be in terms of your site, what makes most appropriate sense for you in terms of it. This intervention does not preclude you from using your best clinical judgment in terms of managing your patients, but it does, what we want you to think about is how can you do some of these things a little bit more efficient, right? But if in your clinical judgment, you feel that, yes, the patient should be seen by physician X, Y time, that's up to you, and we're more than happy to adhere to sort of what you want to do. Because again, as we said, this is real world in terms of what people do. And people do different things in different settings based on what their needs are. And this is a pragmatic implementation trial, and we're not trying to make you do everything in one harmonious way, right? Next slide. So, of course, CAS for this grant stands for CAS Treatment Strategy for Hemoglobin Outcome. And then we combine that with the TCP, which is the intervention arm, which is, of course, the training that we talked about, the clinical reminders, and also the practice facilitation. That'll be at the provider level. And then, of course, SIM or screening, initiate and maintenance of hydroxyurEa will be off for all patients. As we stated before, all the patients receive hydroxyurEa, no matter if you're in the control arm or even if you're in the intervention arm in terms of next slide. So a couple of things of importance is the inclusion and exclusion criteria. So the inclusion criteria is that, of course, for the providers, has to be, physician, nurse, could be a community health worker, hematologist, etc. So at your sites in terms of this. So these are what we designated as providers and have experience at least managing sickle cell disease. And I think based on the presentation of this morning, it seems like every site has a certain number of people. Some sites have more capacity and more individuals in terms of managing sickle cell disease, and some are a little bit smaller, but it seems that there is at least, I think lowest number of individuals was maybe 3 physicians at some sites. And please correct me if I'm wrong. For the inclusion criteria for patients, of course, they can have to be either adults, 18 years or older. They can be actually children, anywhere from 12 to 17 years. Of course, they have to be able to provide consent or assent. So consent for the patient, for pediatric patient. And then we're also asking, because these individuals have to be part of the SPARC registry. That is the beauty of this particular work, is that we're using an existing network that that's here. We're utilizing the patients that you have in your registry. And then, of course, they have to be hydroxyurEa naive. And then all these other things in terms of phenotypes. And of course, for children, they have to have parents or a guardian consent for assent. Next slide. And then the exclusion criteria, I think you already know this in terms of including your patients. And so they're unable to participate in activities for any reason. So any patients that are not part of the registry, part of your existing registry, of course, would not be excluded. And then just various other things, for example, pregnancy. The other thing is, because we have to screen, initiate, and maintain, these patients could be hydroxyurEa naive in terms of where they are in terms of the registry. And I think that you all would have the clinical really do that. Much of this information in terms of patient and inclusion and exclusion criteria also came from the REACH trial, which I think many of you are familiar with. That was the hydroxyurea trials that occurred in sub-Saharan Africa, showing that hydroxyurea was actually effective in terms of managing sickle cell disease among African adults and African. Other exclusion criteria based on that trial is people on ongoing chronic transfusion therapy, and also chronic utilization of medicines that could be toxic when they interact with hydroxyurea. Of course, that would be one of those screening criteria. And then also, and then chronic illness, which could potentially be enhanced or increased with the utilization of hydroxyurea. So again, this is based on your clinical judgment, based on the evidence you have for you. So we're just basically asking you to look at this. And this is something that you already do on a daily basis in terms of management of your patients. So we're not really asking you to do anything beyond these things other than just be cognizant and interpret. Next slide. Okay, so basically we're getting toward the end of this. So screen, so many of you have screened the patients. They're in the registry in terms of it. So approximately anywhere from 42 to 50 or so. And then for the patients that have been screened, of course, initiate hydroxyurea, counseling and follow-up laboratory monitoring, things that you do on a regular basis for individuals, hydroxyurea, and then maintain. Do you maintain those dosage over time, or do you decide to not allow the patient to continue on hydroxyurea? And we do recognize that there will be situations in which you might say that this patient, after 6 months or so, should not be on hydroxyurea. And that's perfectly fine. Again, this is your clinical judgment in terms of how you manage your patients, but we just want to make sure that what we're doing in terms of both training and then also providing hydroxyurea are not barriers that we see in terms of managing that. So that's at the provider level. At the patient level, that's of course a different ballgame and role. So screening, of course, patient history will collect some of these. Did you have a question? Did you have a question? Okay, I thought you were here. So of course, completing a detailed physical exam, completing a growth chart. So again, we're going to talk about all of these things. It's in the baseline forms that we'll really do a deeper dive into. So we'll really talk about those particular case report forms tomorrow. But this is basically the screening process. Next. initiate. So initiate hydroxyurEa for the patients, and then basically based on your own clinical judgment and terms of it. So initiate hydroxyurEa. Very simple, straightforward. And then next slide. And maintenance. And then basically maintenance of hydroxyurEa. And the issue here is that we know that based on previous studies, there's a low level of hydroxyurEa utilization within Africa, and we're trying to see if any of this training will increase that particular level of hydroxyurEa utilization at the patient level. And next slide. Sure. So. Okay. Yeah. So I've done this. Go ahead and do this. Okay.
Thank you so much for starting the models. Also, the county wall, so the next few slides, so we talk about LMlCs for sickle cell disease management, and you see that it was here for adults. It is simple to explore what you increase to the maximum tolerable dose. They're using 50 hours with orally once a day. Patient immediately and then for children less than 18 years of age, also is 50 dose of the with organs that are entirely growing. It was also changing with regards to the body weight. And underlying the job that sit on responders, patients will respond after only of the therapy. Or show no overall improvement and they should be discontinued. And on the right side are the small side effects, lactate, which is closing the urine, changes called EBIs, you all know that salt roads and AST, difficulty, so those are the common things that we have. Because here still statistics have been shown to be very effective in a lot of countries with more also basic monitoring counts with the regular monitoring of clients in the study at no cost. Monitoring will continue until the patients are enrolled in the national health insurance. Also, so this will be really cause of what is in all expected medical condition occurs during treatment. It may or may not be related to the investigational product, but it may or may not be related to the drug being used. All right. So they don't have to be caused by a drug. It's also an untold medical occurrence that occurs with the use of drugs in humans, whether considered drug-related or not. And they include the following: overdose, drug abuse, drug withdrawal, and any failure of medical action, and then the penalties to not those are the adult events. Okay. Now, this serious adult event and SAE is a reaction defined by any adverse event that suggests a significant contraindication to occurring. Example includes fatality on the patient dies, or the patient becomes a PCO, or any need for hospitalization through the course of use of that drug, or any anomaly, or any medically significant life-threatening complication or hold. These are severe adverse events, and all AEs and SAEs should be immediately reported using the adverse event form. Also, when we report AE or SAE, once an AE is recognized, it should be reported. This is done by completing the AE form. Please submit all the information to the study coordinator on the university panel. So across the country, all the different sites, we should submit the AEs to Abuja, which is the central site, and then also with additional follow-up. For instance, somebody has acute chest syndrome or some complication that arises because of initial reports sent to UA. And then when it resolves, or by doing this, if we don't report to say it ended on XYZ days and it was what we did or what we did not do. So these are the forms, there is the forms. Here we have indices like the primary alcohol measure, all right. We have the rate of adoption, which we are discussing. The secondary alcohol measures, the forms 10, 11, and 12 are also available. Just on the slide summarizes the various forms that will be filled in the study, all right, and the times for us to like the next one. Right, so we have looked at this before earlier in the morning, in which we saw the different forms and the different times of filling them for baseline or 6 months, or 10 months, or 18 months, or 20 months. All these, I think, will require us to be very critical and not get to be this. You will need to screen patients at your clinical site of sickle cell disease and identify probably 42 to 15 sickle cell disease patients. All right, you have to initiate hydroxyurEa by identifying patients, counsel, and follow up. And removing patients because they children as the government. But remember that it's not really a change in dosage, but the milligram per kg remains the same. Just that the child is growing as we need more of that. Now, to prevent all related diseases using these study forms. So, I think that you should also make one or two comments. So the actually to say that victims of our successes So you succeed in something. But your success makes you a victim. And the example here is that you have to enroll 14 patients actually. When the initial follow-up studies you had done, the rate of use of hydroxyurEa was quite low. Now, our research knows if you put up to 10, 50 patients in our database, she will get only 2 or 3 that are not already on hydroxyurEa. Because we are only TCD discriminating TCD, patient people are aware during health talks, they're asking for it. And more patients are getting to it. But it is when we get so often they are done just 40. It's been difficult. Many of them are entering, like in the US, the clinical trials, they hardly find the inclusion criteria. But almost everybody is one. People will not deny them of the beauty of the drug because I'm waiting for study. And then there are our peers of advanced shifting, even in the UK, and colleagues also there have challenges. So that's creating some issues among them. Also say that in Nigeria, I don't think TB is as common as Sickle Cell Disease. And task shifting, task sharing has been done in Nigeria. In the past, only doctors treated tuberculosis in Nigeria. But in the past, like 5, 6, 7 years now, any doctor can treat TB. Primary health center, TB is being treated. HIV before was being treated in a specialty center, HIV people around DNA PCR and everything. In Nigeria today, primary health everywhere is called diagnose and treat whatever. People treat TB everywhere, empowered by the government. They have the facilities, the basic normal things, and the patients are doing well. Finally, if you look at the population, 2% of sickle cell disease and still 200 million EBIs. If you calculate what that would amount to, do we think all the facilities in Nigeria can attend to all sickle cell patients in the country? Yes or no? Looking at the anemia and a population of 200 million, if all the sickle cell patients say, I want to be treated in a specialist center, can be cool. So one point at nobody can read. Even the visit, I'm sure we make it way. It's very, very much. The time is now. Thank you.
We can achieve that because most of the patients are already aware. We do advocacy, we talk to them about it, and some of them are on it. Then there are some of them that are on it but have stopped for a long time for specific reason, usually cost. We're going to and we put those ones into the program.
So that's a great question, and I'm going to let my colleague
There's one of the high intensive HU pregnancy. So we have to look a little bit more. We have to look further. One of the things that we are doing here is that we check like management of sickle cell disease, a party program. And we actually started that program as a result of the 4 million Nigerians, right, that were not reaching yet, that are within the community. And we found that as we go into the community to create awareness, to sensitization, that we are beginning to mobilize some of those patients into the hospital. So those are going to be very important. So I think we should do a little bit more in that sentence, right? We should work with the community, the family health, the community medicine people. We should create awareness. We should go into the community. We can identify many people who have sickle cell disease, but they don't want to. So if we do that, we'll definitely have more people who will be eligible, but it will be difficult to go to quarantine, right? And I want to do this concept and start for a long time. If they can. Start again. Yes, because the provider has all on their device. I think this one as a provider issue.
Very much. And I think what you actually said is a better solution to the problem. As in trying to, go do more awareness so that more patients can come. So for instance, in my center, like almost, on every clinic, you see 1 or 2 patients that will come. Even some of them, they will be told about the hydroxyurEa, not that they've started that. They will actually come to the clinic, purposely that, oh, somebody mentioned that there's a drug here, and they will come and do that. So now what I want to ask Prof, so when I have our attention, I'll continue with that. Hello, I'm talking. But what I've said is that what you propose is actually way to go. As more advocacy, there are still so many people there that even they are not coming to the hospital or they have not started hydroxyurEa. So I said from the experience that we have in our center that almost on every clinic day, 1 or 2 persons will come in, oh, there's a drug that is they're talking about here. Just because of hydroxyurEa, that's why they come to the clinic. Somebody must have told them about that. So now what I want to say, that part of the protocol is in such a way that those recruited should be on the SPARC-NEt registry. So for us to implement what you said, which is the way to go, so does it mean that we should just enroll more patients into the SPARC-NEt registry, especially those that are naive, so that they can just fall into the program? No, it doesn't need money for them to be part of. Yeah. It doesn't. So just for us to upload to Mr. Ruben and add it to our data.
Well, let me just say something. We can use 2. I think scientifically we can use 2 milestones. We want to assess first mechanism of hydroxyurEa. And for how long do you scientifically think it can act? Some people will need you to reference what you say. But I think the lifespan of the red blood cell
or the lifespan of the folate stores if you stop eating folate again, which are the two things I think it can affect. Though it has other mechanisms of action, but I don't think any of them will last any of those. Especially the store folate strong. And so I think we can use that criteria. Because the red blood cell that you are affected today, after 4 months, 420 days, you don't expect to see that red cell circulation anymore. Though we know again the bioavailability of the drug will last for more than 24. But I think if you take 6 months or 1 year, I don't think the effect of hydroxyurEa is.
And stopped, and we enrolled that patient. And we were doing another study. The history will be very the evaluator was even the report. Yes, on the transition experience, yes, very good.
Implementation signs, we tend to measure implementation sign outcome variable. So if we are to take in patients that are not hydroxyurEa, I feel it also will affect the fidelity of the protocol, which likely we are supposed to ensure almost close to 100% or 90 to 100% fidelity in the research itself. Thank you.
I thought that was a comment, not a question.
I think in the absence of any more questions, we've come to the end of the session on C. Thank you very much.
Thank you, Dr. Kama. We are going to go for lunch now before we come back for the other sessions. So lunch is ready at the back of the field, and those who ask, I want to be for you to start with time. We are not a lunch where behind the same place for the students. Hmm? 25 minutes, please. Please, I'm pleading, just 25 minutes.
The second part, you're supposed to split up.
Yes.
Where was that?
So,
I assume that
Mr. Tayo, fallouts and so for all those online, good day. If you can hear me, we're about to start the next session. So those who are on okay.
Good day. I can hear you.
Yeah, so Joyce, where I am now is where you and John will be handling.
Okay.
So we just split the group now. Dr. Pepper will take the other group. So where I am now, John is already here. We're trying to load up the slides. So
Okay.
you would take those who are here.
And everyone online is in the task group, correct?
Yes, so we need to I need to find out those who are online. So let me just quickly make this announcement. Mr. Ruben is going to go online. Yes, right. Yes. So yes. So just hold on a bit. We want to move some of the people who are online, who should be in the SIM only group, to the next room. So we'll just call out. No, you wanted to choose based on their center, right? Okay, so please, those of us who are control and experimenters. So control arm, and experimental. No, experimental is for this place. Hmm? Okay, so you stated it. That's what they will see, right? Okay, so please, if you're still hearing me, two rooms have been created. I'm sure you're seeing that. So if you belong to any of these centers, please, you would log into the control room. If you're in any of these centers, please log into the control room and not the experimental room. So if you're from Ahmadu Bello University Teaching Hospital or Alex Ekwueme Federal University Teaching Hospital or Jos University Teaching Hospital, Lagos State University Teaching Hospital, that's last suit, Nnamdi Azikiwe University Teaching Hospital, University of Abuja Teaching Hospital, Pediatrics, University College Hospital, if you're a research assistant from any of these places, University College Hospital, Ibadan, and University of Nigeria Teaching Hospital, UNTH. Any of these ones I've listed, please log into the control room. The rest would remain in the experimental room. He has, okay, let's just stop them. Because I can see everything here.
So that way you put people on the right. But then having said that,
our colleagues need to think about research questions which can be done across the consortium. And so we have Dr. Anna Maladu, a consultant hematologist, and her colleague, Dr. Pakuri, who have gone and done some great training in the UK, and they are coming back with very exciting research opportunities. So they are going to pitch this idea to us, and then collectively, as usual, we'll see how to contribute, ask questions, clarify, and then we'll see how we can make it work. Because having the registry is very important, but then adding additional studies is even more important going forward. So we have that resource. So I'll stop talking and give them the floor. So we listen carefully and we see how this study can be done.
Thank you, Rob. So I think this is, I've done a 3-minute speech when they just asked you to summarize. This is what has just done to us. We thought we were going to pitch it tomorrow. She said, you do it now. So I tell you, I'm not ready. I said, come, let's go. So basically what we came up with this idea with, as clinicians, Accelerate, we understand has a lot of potential, and we are excited that we have this opportunity to provide hydroxyurea to our patient. We're not trying to reinvent the wheel. We know that one key thing about hydroxyurea is organ protection. And that has been proven in different circumstances. We have major studies that have shown hydroxyurea prevents stroke, especially in centers like Kano in Zaria. So, but what about the other organs? So we feel if we have patients who are hydroxyurea naive, and we're going to have them on hydroxyurea for 2 years, well monitored, well controlled, well observed. Why don't we came to this opportunity to see as clinicians what are those other benefits that we can get out of this study? So we were speaking with Opaku and said we can look at. We know that people with raised TRV, is it possible that hydroxyurea can reduce it? My PhD was on a spleen, and one of the things I noticed in the few patients that were on hydroxyurea was patients who were on hydroxyurea tend to have their spleen persisting, and they tend to have low homogeneity burden. So these are all contextual because the sample size was small. So this is something that we can scale up and see. When you read literature, most of the people, the researchers privately have baseline data. So we feel let's try and maximize this opportunity. We've thought of 4 that we want. Can we look at baseline data on renal function, on echo and cardiac function, on ophthalmic changes, and then the spleen, pre and at exit? But we're cautious that we don't want to touch anything that is going to be, in Accelerate. So we just realized in Accelerate we're going to be looking at renal function. So we're taking that out of what we want to do. So that brings us that we have 3 things that we want to do, like baseline and at exits: the heart, the eyes, and the spleen. And I think you also suggested growth. Yes, and we can monitor. So that's a photo that we can impact. But the reason why we came here is we're all cyclists. We want to open this, to suggestions, to feedback, to criticism, and can we do this? If we want to do this, how do we take it forward? So that's why we're here to speak on this note. Thank you.
Yeah, thank you very much, Dr. Adama. Just to add to what she has said. So you discover that if we search the literature, there's still so many studies coming up on hydroxyurea, the different aspects of hydroxyurea. So we felt that this will actually be a very strong one if we are able to do any of these. The reason behind this will be that this is going to be a multi-center study. And with the number of patients that we'll have, from the different centers, put them together, it's going to be actually huge. So that, and I think some of those things have actually not been looked at if we check the literature. For instance, now we're talking about the ophthalmologic features, getting some parameters before starting the hydroxyurea, and after starting the hydroxyurea, getting that again, so that at the end of the day, if these are published, it will be an impactful one that it will be able to progress knowledge in the field of sickle cell disease and hematology. So the ones that were considered, as she has said, is talking about the cardiac aspect. So at least from some literature that was said, you discover that the cardiac effect were actually mostly done, maybe retrospectively or in a patient that is not well planned like this. But this one, if we're going to do it, that means it's well planned. It's going to be a longitudinal study that will follow up prospectively, knowing the baseline value. And afterwards, giving hydroxyurEa and check that. So with that, we'll be able to establish causality. Because some of those studies are actually just cross-sectional study, and we'll be able to establish causality. So then, in addition to that, there is effect of hydroxyurEa on the spleen, so also on the eyes. Then we talked about, we know that in the OG study that was done, initially, they talked about, they looked at the growth and compared with what was done in the cooperative study that was done, sometimes back. But this one is going to be like the one that we purposely do, planning from the beginning and also at the exit point. So, and what we feel that the parameters that we're going to study, although we're going to get input from every one of us so that we are doing it together, they are not parameters, they are parameters that we can actually get done easily. Some just by physical measurement, like for instance, talking about the growth. Then other ones that will involve maybe some tests that will be done. They are not expensive tests. So we now felt that doing it along with what we're doing, it's just going to be like using one stone to kill, multiple birds, and at the same time getting impactful outcome. So I think the floor is open, for people to make impact.
So overall, it's a great presentation. I had also thought about the cardiac element of it, which was, I wrote a little bit of a thing about it, but I'm glad that you both were thinking along the same lines in terms of it. I do agree that there's an opportunity to use the accelerated study to look at some of these secondary clinical outcomes. And it's a significant addition that we can add to the literature. As you have already noted, this information, this data does not exist. There are hints of it here and there with small studies, but thinking about the multi-site study and looking at these secondary outcomes, I would say that because we're looking at it as secondary, we will probably not do causality, but we can do a strong association to show that being on hydroxyurEa leads to better outcomes. The only thing we will have to think about is that we will also have to look at individuals that are not on hydroxyurEa too. So in terms of the general monitoring of everything, we would have to also think about that. So we would sort of need to do two things. Think about the power population and what's the sample size. We don't need 600 people like we need, for accelerate. But what is the minimum sample size that we need for this? And then what would be, then we will have to compare with the comparative group, which would be individuals who are not on hydroxyurEa, and just to show a strong association. Because I think overall, what you want to show is the benefit of being on hydroxyurEa, right? It's like,
I think we're weighing two things. We just thought if you have an longitudinal group, you have a baseline and an exit, you may not necessarily need to have those patients who are not on hydroxyurEa. Yeah.
Okay, so we would just want to make sure that
we have collected enough preliminary data for the head time, so that when we start,
Send
that we
the,
can then
I've
have that.
forwarded you the post-slash
So that's
evaluation. You know, you share with those people online, Joyce them. So please, if you just post it, just start online that please you should. That's the post cash evaluation. I hope nobody here has joined that.
I think we're conscious. We don't want
Same people. No, but you know the people who are online now. Joyce, what was the Joyce? What was his name? This guy.
Yes, Joyce, Adebojo and Fatih.
Something. You understand? This guy.
Okay, I think it's Halima.
I'm here.
Not something, right? In fact, you're the one who should have sent it.
The mic.
So when it comes to many of these clinical trials that have clinical endpoints, as you all know, they usually use like a few labs so that everything's standardized. Because this is a multi-site, we have to be careful
Sent to Joyce.
how we
See that?
okay,
no,
different
sent
sites.
to Joyce.
We just need to make sure that all the sites in terms of clinical labs where they're coming from, they are they're using very common protocol. And then also, if we have, let's say, 5 or 6 blood samples, we want to share among all the sites. We want to make sure that their variables are consistent. And that will show that there is internal consistency among the different clinical labs that are using, so that we can have confidence in the data. So we can think about how we can do something like that, but we would have to make sure that even if we're using different sites, there is some sort of correct that.
So I was about to suggest nephropathy, but it seems as if you talked about it. But I think I can want to suggest CNS, because CNS is also very important. So if we could look at TCD before, or that's at onset or at enrollment for all our patients, and then at the end of the project, we re-evaluate with TCD and see whether we would have a better average for all patients, and that would mean that somehow we have a better situation. I think we can look at that and also contribute to that.
I see it.
So, sorry, I'm sharing the evaluation. Was that the request?
No.
I think that
No.
They are focusing on the ones that haven't really been done in Nigeria.
Okay.
TCD1, quite a number of people outside the country and inside the country have actually established that hydroxyurEa alters stroke risk categorization. And so it's not really in question. It's been done in Nigeria. That won't do at all with the number. We published different papers about this, so I'm thinking that's why they're not thinking it. It's not that it can't be done, but they are beginning to label the accelerate program. We are beginning to add to it. Sorry, you do, but how many of our centers have TC? That's the thing. What I'm saying, the majority of the centers will have the same type of TC. You can't use a mix of non-imaging and imaging TCDs to do a study. So I think that's why TCD may not.
I have some sticky clarification from some of them. Yes, ma, I seek clarification about the NIH perspective. These studies are fantastic to landmark.
NIH experts. We are looking based in NIH and you once registered. I don't know if someone you see we funded a particular work. We are giving yours just before and after, and you are taking owner. But that has to do with agreements. Just clarification.
So the Accelerate study is an implementation science pragmatic clinical process. We're collecting additional data in terms of making sure that patients are number one, being adherent, making sure that in terms of any toxicities, etc. If we collect these other parameters and do secondary data analysis on it, the NIH can just say, hey, their money went to additional data collection, that's data that was already being collected, and more came out of the study than just the primary outcome, the secondary clinical outcomes that were analyzed. So it's not a question of is the NIH going to be upset. It is because we're adding more to the data in terms of sickle cell disease. It would not be an issue from my perspective. We just can't get any more money for it in terms of our study. But there is secondary data analysis that occurs all the time. In fact, my team has looked at some studies and got secondary data analysis on that. So it is feasible. It is fine, long as it does not compromise the initial study that we're doing. And none of these things that we talked about, as far as I'm concerned, compromise the initial study that we're doing. Because again, we're looking at that primary outcome at the provider level. We're still collecting clinical outcomes overall well-being and everything else. And then also looking at adherence and all these other parameters. So yes, we could look at those data, publish those data, but we're not changing the aim of the study or anything like that. It just becomes sort of like a secondary analysis.
Thank you. I think
we last first. Okay, I'll give you first. Okay, so
I can almost take the cash. Please, right? Going to send us whose very same scheme, which is where everybody
okay. I don't know whether we have thought about pulmonary hypertension. You have, okay.
Let me just let me just speak something. Which also wants to speak. I just want one or two things. Wonderful idea. As a matter of fact, when you sent it online, I was so happy and overjoyed, and I felt so. This is beautiful. All I think we need to do is to tweak it a little bit so that we can shift exactly what we want to do, and we won't have so much additional expenses that we have to pay. If you want to do, I think it's also, I suggest that we take things that are quantitative, things that we can measure. If you want to do before and after, a good way to start is going to look at our clinical phenotypes, that published study. It gives you different phenotypes that we've published. Look at those that are measurable, that you can do now and you can do after 2 years. If you can't do TCP of the middle cerebral artery and the other one because it's been published, I can tell you that you can do TCD of the ophthalmic artery. Somebody did that after 2 work, and it showed serious correlation with orbital findings, ophthalmic findings, and staging of the sickle cell retinopathy.
can run the TCG of the ophthalmic artery now and run it after 2 years. At least with the velocity, you have something that you can work with. You can even do leg ulcers and measure the size of the ulcer. That way you have qualitative and quantitative. If you measure the size of the ulcer and the characteristics, you can. Because that's also one controversial thing. Some people are saying hydroxyurEa affects wound healing, so you don't give it to people that have leg ulcers and things like that. So you can also make a statement about that. Of course, pulmonary hypertension is there. For those that can do the echo, okay, with the TRV, you can always get what you want. So, but let's not gather all our meals in one basket. It's better we take the ones that we can. You can also check albuminuria, which is the first sign of the flu pattern. Okay, microalbuminuria, so you can assay it at the beginning and assay at the end. Also, GFR, but GFR is a bit controversial because some people say in sickle cell patients, you don't use the regular eGFR calculation that other people will use. But it's again another thing that is quantitative. And I don't know whether Accelerate is looking at the eGFR or just on the property. So there are a whole lot of things that you can just look at the published work on the phenotypes of SPARC from the sites, and you have myriad of things that we can easily throw out. Thank you.
So, assessing the spleen, because we said we wanted to know whether hydroxyurea will make them to have persistent spleen. I don't know, from my own center, the experience I have is that many of our adult patients have persistent spleen than not on hydroxyurea. In fact, some even have massive spleen that they carry about. You know, I have also lost some adult patients to splenic sequestration. Initially, I noticed that they have, you know, they are clinically, they are more stable. They don't, most of them have never received blood transfusion before. They hardly have crisis. And then I was like, okay, it's like this is a good, you know, prognostic, seems to be good. It was when I started using some of them to sequestration that I now changed my mind and said, this thing that I'm thinking that is a good place is actually dangerous. Even some in pregnancy have lost the sequestration in pregnancy, you know. So since after that experience, once I see adults with big spleen, you know, some will just have normal size spleen, like some will have like spleen 10 cm, 8 cm below the left, and they carry it around and be going, no problem. Then when I lost some of them to splenic sequestration, I now changed my mind and started going after the spleen. Now, once I see spleen in adults, I will liaise with the surgeons, we immunize them and remove the spleen. You know, so when I now interacted with some of my colleagues in other centers, how often do you see adult patients with spleen? They say, we hardly ever see any adults with, you know. So I was now wondering, could it be a different haplotype or something in a center or what? How come many of adults, almost like 40-something% to 50% have normal, and you know, so that kind of study now, if you say you want to give to see if it can help them to retain their spleen, that kind of population, it will be difficult for you to really interpret, because even without hydroxyurea, many of them have big spleen, you know. So I don't know whether other people have that kind of a scenario in their centers too. And there are publications. Yeah, there are publications, and I think I've come across 3 publications about retaining the spleen into adulthood. And the figures are a bit more than I imagined. That the one was 23% at 30 or something, and that was a lot, because we all thought teenage adolescents, some in adolescence, so I think you should just check with the treatment, and I think you see quite a number of
situations, and it wasn't as a result of hydroxyurEa. So the other thing is measuring the spleen. I don't know what parameters, clinic parameters you want to measure, but remember how it is with the OFC when you are monitoring for hydrocephalus, the possibility of hydrocephalus in a child that has had meningitis. It's not the same observer. It's not the same observer each time. Then inter-observer variability might frustrate the value of the results. Just to remember that. Thank you very much. I think this has sort of ignited interesting conversation, new insights, and we're really happy that we're getting this positive response. So because of time constraint and everything, thank you for the opportunity to pitch this. But I think in terms of next step, we may need to have a meeting, an online meeting, and where we can sort of, I think what we're suggesting is highlight which are the organs that we want to take forward. We have a lot of suggestions, but look at practically, we want to embark on something that doesn't need a lot of effort. Less additional laboratory testing, so we have to be mindful of that. Like somebody was saying, let's not overburden the accelerator group already. So we're quite mindful of that. So I think the next plan, let's have a meeting and then let's conclude on what we want to do. Once we can identify what we want to do, and then we are suggesting for each of the organs, we're going to have somebody that's going to lead. So somebody that's going to lead the cardiac, somebody that's going to lead the spleen, somebody that's going to lead if it's a leg ulcer, so that that person can, sort of design a proper protocol, and that's, we have fidelity across all the sites. For example, if you want to look at the spleen, should we just look at spleen length, because everybody can do that across the site? If you want to look at TRP, should we get a cutoff value, let's say 2.5, something that is replicable without a lot of bias? So those are the kind of things we want to address before we start implementing hydroxyurEa. So I think we don't really have much time, and so that we can start on this. And then just to add, there is no funding for this. There's no accelerated funding for this. So that's why we're trying to avoid anything that will incur extra funding. So unfortunately, it may be that, like in my center, we may be able to have echo free of charge because we have collaboration with cardiologists. We may have abdominal ultrasound subsidized or even free. So those are some of the sacrifices that we just want to mention at the outset. And going forward, hopefully, if we're able to secure funding, then we'll be able to do more. But I just feel it's something we need to open out before we take the next step. Thank you.
So I think that's a great idea for the next step. The only thing I would say is that we need to also think about protocol modification. So we need to sort of make some of these decisions because we will, if we need to make the protocol modification, we need to make them do that. Well, at least NYU,
Can I ask a quick question? Please? Why are we talking about nephropathy accelerate? Is it just because of the serum electrolyte? Is there any other feature of renal function being assessed? Just electrolytes, no? Any other thing they are doing?
No, from the proforma, the CRF, it's not just really the electrolytes.
They do electrolytes.
They're also assessing the urea, the creatinine, albumin, creatinine ratio.
So they're going to make a statement on renal function.
Yes.
Because I'm just thinking that simple urinalysis albumin, as they said, or even proteinuria is a very simple one to do, and that's one area use of hydroxyurEa is being challenged. Do you start patients on hydroxyurEa once you record albuminuria, or even when you have proteinuria, 1 or 2 pluses? Do you start them on hydroxyurEa? Is it going to improve? So if it doesn't contradict the accelerator, we can also consider it. It's so easy to do urinalysis and check for macroalbuminuria. It's the micro that may cost us a bit of money, but it's nice to actually do the micro.
So I don't know if it, how it contradicts the.
Okay, that was actually in our original plan until after we checked today, even it was today that we realized that some of the parameters that we tend to measure, which you mentioned.
Are they doing albuminuria, micro and macro?
No.
Is there any contraindication? It's a very practical use for hydroxyurEa.
All right. So I want to appreciate every one of us, you know, for the
So Syria, then we scared that it may affect sperm count. I don't know whether we can also consider assessing the equivalent testicular function by doing sperm counts or seminal fluid analysis before, then commence hydroxyurEa, and then later. No, it's true. Our male patients, they display a lot of phobia about seminal fluid now. They will produce a lot of vertical issue. So how do they get it now when we want to do seminal fluid normally? No, it's not basic now. It's not. How do they get seminal fluid or to do analysis normally? They get the seminal fluid now. That's why I said, if we do it, we cannot have or intense effect. I don't know, but I'm just thinking because that is a lot of many of them will tell you that they don't want to. One of their reasons, especially for men, is that it affects the sperm counts, and they wouldn't want to take hydroxyurEa. It's one of the concerns the main patients express.
Okay. No, thank you very much for that.
This additional data out of accelerate, we really cannot answer all the questions you have in about management of sickle cell. And quite considerable work has been done on this. Even in this country, it's agreed that it can alter stomatogenesis, but it is reversible in 3 months or thereabouts. Stopping hydroxyurEa. So it's work. It's a lot of work to do something that has been proven. That's the point I'm trying to make. We are happy that we are adding additional things. But if you go take on TCD, take on echo, take on seminal fluid, I think that it is very, it's getting wider. Pardon? No, just the seminal fluid is the reason I'm saying it. The other ones are less clearly proven in our environment than the seminal fluid one. And I think I don't know what you need to be collecting the seminal fluid. Is it hematology? Or you don't?
Okay, thank you very much. You know, I want to appreciate every one of us, even for warmly receiving this proposal, and also for the stimulating and anxiety discourse that it has brought. So we hope to continue it on our platform. Subsequently, I will schedule a meeting so that, and hoping that we'll be able to achieve this. So that at the end of the day, when it's published, it's actually going to be impactful. Because as it was mentioned earlier on, that some of the things that we're considering actually not being done, even generally global. You know, some not in the way we're going to do it. You're not talking about the methodology. So thank you very much. So
we should really give them a round of applause. Yes. That's excellent. This is what we want.
Okay, so practical things. This project now can easily be funded by several IBRs in our institutions because IBR is now 5 million. Tech fund IBR. So assuming that we get each of the leads for the different organs, write a proposal, multi-center study, we can easily fund that. So it's depending on how much leeway you have in your institution, but let's think about it. So this is really good. Well done.
It's been an exciting workshop, and I want to believe that we've all done our individual posters. You know, the workshop cannot be complete without a poster.
WhatsApp. Individually, yes. Dr. Kelechi.
Individual busy.
Yeah, but we have to know the person that's sick. Dr. Kelechi. Okay.
Talk to him. Is him now? He's asking if you sent to him. He said that. Professor Focha.
He said he does not. Just
go and meet him. Which will remind you of to your
So on a personal note, I can actually say for myself that my implementation science horizon has been wide. And with this, I want to call on a person to give the
So this has been an amazing and exacting thing. I'm really, really happy. Not the least because of these new ideas that are coming up from the fact that we have a resource that we can build on. This is really fantastic. And I want to thank all the research assistants who have been here all day, you know, just listening and participating and asking some questions. I want to thank Joyce. I don't know what time it is in New York at the moment, but you've been here all day too. So we have enjoyed hanging out with you. We need some people in Abuja, right? And we hope that the next time we'll be here. So I want to thank all of you, and this is what is typical of our consortium. The sustained interest when we come for any program or any meeting. And I want to thank all the staff from SESTA, you know, for actually facilitating all of this. Thanks to Professor Maxwell, and thank Tayo. This has been an amazing workshop. Thanks for all the background work. So thank you. Thanks to everyone. For the people who are off-site, wish you journey messages as you go home. And I apologize. I understand that they took the night. In this hot environment, honestly, I have spoken to the manager. I will put his phone, you know, on the accelerate group, and you have permission to bother him. But I think we should go beyond that. I'm talking to him that he should give you electricity. He says it's uncommon for there not to be electricity in the evenings. So please let us know anything that is happening right here in the night. I sincere apologies. Thank you. Well, thank you very much.